Good morning, ladies and gentlemen. I'm delighted to welcome you to the 7th edition of the Oesophageal Neoplasia Masterclass from a very overcast London. I'm joined here by my consultant colleague and better friend, Rehan Haidari. We have a really exciting program lined up today, covering a breadth of topics, including the initial assessment of Barrett's through to uses of artificial intelligence, through to very advanced endoscopic therapies, and really covering a real plethora of topics which we are hoping will engage the audience today. And really, this has stemmed from feedback which we've received over the years. So it's a real pleasure to have you here today. I'd like to begin by firstly thanking all the national and international faculty who have really stepped up to the plate to deliver some excellent material, which I'm sure you will all enjoy as the day unfolds. None of this would have been possible without the support of colleagues and industry, which are demonstrated here, and we'll be demonstrating a lot of technologies which are currently available, but also soon to come, and really give you a foresight into the future moving forwards. I'd also like to thank the Gastro Learning platform, which is hosting the course today. Encourage all delegates to use the platform to put their questions through, which we'll do our best to answer real time. And importantly, if you're not able to dial into any of the sessions, the content will be available on demand for you to view whenever you like. I'll hand over to my colleague, Dr. Haidari, to introduce you a bit further and kind of set the scene.
Thank you, Vinny, and good morning, ladies and gentlemen, wherever you are in the UK, wherever you are in the world. Welcome back, I should say, to the 7th ONM. It's our 7th year now running this course, and each year we have grown and tried something different, and this year is no different. We have a real mix of exciting cases, lectures from our expert faculty, and also some really intriguing, innovative developments in the world of the management and diagnosis of esophageal neoplasia. As Vinny said, let's try and keep this as interactive as possible. We rely on the feedback and the comments that you put through in the chat function. We'll be trying our best to answer those and discuss those as we go along. So I think without further ado, we will start the morning with our first case, and we're going to start with Barrett's esophagus. And we're just going to start with the basics, and we're going to have a look at a case of a patient referred to our centre for a surveillance endoscopy. So a gentleman with a long segment of Barrett's esophagus. And we're just going to look at some of the chromoendoscopic techniques that are available, from electronic chromoendoscopy to dye-based chromoendoscopic agents. And we're using the Pentax system here, from the 2990 series, the I10 gastroscope. So let's go over to the first case, and then look forward to discussing it with our expert faculty in a few moments.
Starting off with assessing a Barrett's segment, you'll see that you had a pool of some bile there in the bottom of the esophagus. When you're suctioning and assessing in Barrett's, be very careful not to suction the mucosa. You don't want to suction mucosa into your scope and then create a fibril area or an area that then you can't assess. So just when you are suctioning, just particularly Barrett's assessment, have it at 6 o'clock and just suction gently so you don't suction mucosa up. And what we're going to do to start off with, obviously, is assess the Barrett's. So the first thing we want to do is find our GOJ, and from there measure the length of Barrett's esophagus using the prior classification. You can see I'm just cleaning here, and in my cleaning fluid we have just water and of course some N-acetylcysteine as well, just to get rid of some of the mucus. Now, what we're looking for here is the top of the gastric folds. We don't want to over-inflate the esophagus. And you'll see the top of the gastric folds is about here, which is on this gentleman's esophagus about 39 centimetres. Approximately here, there we go. You can, if you want, as I said before, look for the palisade vessels, which you'll probably see better using OE actually. Let's have a look, let's click onto our OE setting and look for our palisade vessels, which will be, there we go, some of the deeper running vessels just there, just to confirm our position, but there we are. Let's go back to iScan 1. So I'm using the Pentax I10, and I'm on the mucosa enhancement setting, which is iScan 1. And what I'm doing now is I'm just going to measure the length of the Barrett's just by coming up. You can see it's all circumferential here, all circumferential still. And there's the top here actually. So it's a totally circumferential segment. Comes down to 31 there. So that's C8. And then the maximal extent is also 8. So C8M8 for this gentleman. Okay, and then what we're doing, so as we talked about before, is using 1 minute per 1 centimetre of Barrett's esophagus. And all I'm doing is I'm just going up and down the esophagus here. Always assess looking for dysplasia, even if the patient's had a scope recently or had a resection from a colleague recently or whatever it may be, always up and down looking for any evidence of dysplasia. And you can see I'm just coming back up and down, pulling through the esophagus, looking for any obvious nodules, friability, any ulceration, looking for asymmetry of the way the wall moves. We know between the 12 and the 5 o'clock position is the most likely place one will find dysplasia. And I'm just pulling back through now, and I'm going to flick onto my iScan OE, and I'm going to in a minute show you how to look at the GOJ properly, but all I tend to do is go from above first. So again, you're just going to see me coming back and forward, up and down the esophagus here. And I'm just looking at the mucosal pattern. Now if I freeze frame somewhere around here, oh, that's not a very clear picture for you to see. Hang on a second. There we go. That's a nice clear picture. You can see here you've got the nice tubular villus pattern. So this oval ridge-shaped pattern, that's completely normal. And what I'm looking for is any change in the way that lining looks. So looking for whether there's any irregularity or any areas that lose their shape. Now, but what I'm going to do whilst we're just drawing up this acetic acid is I'm just going to look at the GOJ, and what I've done is I don't know if you saw that I did the J manoeuvre in the stomach, and then I pulled the scope into the hiatus hernia. And the good thing about these Pentax scopes is they really are very flexible. You can get right up in this hiatus hernia and you can view the GOJ from below, which is the best way to view the GOJ, and you should certainly be doing it for all your Barrett's surveillance endoscopies. Get inside the hiatus hernia and have a good look. And then you should rotate round inside the hiatus hernia like this, just to see. And then again, using your image enhancement, oops, sorry. Use my image enhancement settings. I'm putting on zoom there, but actually what I want to do is use my iScan. There we go. So what I'm doing now is just with a dye spray catheter, with a white tube and some acetic acid, 2.5%. So spray here, please, guys. We're going to spray some acetic acid. Spray, spray, spray. Great. And we're spraying acetic acid. And as we've talked about, the cytoplasm within a non-neoplastic Barrett's has lots of cytoplasmic proteins that take up the acetic acid, and we get some acetowhitening, cause some acetylation, cause some acetowhitening, and you get lovely whitening of the esophagus as we're seeing here. And in neoplastic tissues there's less cytoplasmic proteins, and so you get a lack of acetowhitening within the esophagus. So either it's slightly paler or it just lacks acetowhitening. Here you can see at 6 o'clock starts to look less normal, doesn't it now? Let's have a look. So perhaps that friability, and we always talk about if you see friability, particularly if it occurs even washing, that's what should draw your attention. Now interestingly, that's at 34 centimetres. It's the same area we were looking at a minute ago, saying, does that look normal? And that, you can see, actually has lax acetowhitening there. If we... Oh, pause there. You can see in that little patch, there is an area that has not taken up the acetic acid there.
That was a really elegant demonstration there of virtual chromomendoscopy with acetic acid, with the demonstration of a visible lesion there. Very simple to do, very elegant, and something we would encourage those, and particularly in community practices when they're doing their Barrett's surveillance. So just to introduce Mike Wallace, who's flown all the way across here. It's a privilege and honour to have you join us on the course today. Thank you, Mike.
Thank you, pleasure to be here.
Just going to really pick your expertise in this field a bit further. Dave demonstrated there a few tips and tricks for Barrett's surveillance and lesion detection. Do you think when you're teaching your trainees about doing Barrett's surveillance, is there a minimum time that we should spend for a Barrett's surveillance case? Do you map out how long these patients need, or does it not really matter?
Yeah, I think, we'll hear a lot about new technologies today, but I always like to come back to basics, which is doing a very good, careful examination is probably the single most important thing we can do to detect dysplasia in Barrett's. And that 1 minute per centimeter, that I'll actually show the data from Pratik Sharma's trial that supports that. It's like colonoscopy, although, we started with withdrawal time. We know the longer you look in the colon, the longer you look in Barrett's, the more likely you're going to find something. In reality, as we saw in the colon, it's probably more about how you look, how carefully you look, and how you train your eye to detect the kind of subtle things we saw here, that slightly depressed area, that slight mucosal irregularity. And that obviously took, we were watching that for 2 or 3 minutes before any of us saw that even on the screen. I think the technologies, whether it's chromoendoscopy, optical-based chromoendoscopy, confocal, OCT, and AI is the new kid on the block now. All of these, likely tell us that there's something there, but often what we see is when you go back to just your regular view with a careful exam, you can often see the same lesions, but they are good teaching tools.
Yeah, and we know that there's a very wide area of coverage in Barrett's, and random biopsy sampling can often overlook that. Is there anywhere that you kind of focus particularly certain hotspots in the esophagus?
Well, we heard again in the commentary there, for reasons we don't fully understand, the right upper corner, the 12 to 5, seems to concentrate a lot of dysplasia. We don't know why that is, but epidemiologically that's been shown in several studies now. But the reality is we look at the whole segment. You look 360 degrees, you look from 12 o'clock to 12 o'clock. You obviously want to wash well, clean well, make sure you've got a nice field of view. And so I again, when I teach people how to do an examination, it's all about spending time, looking carefully, clean field. It's the same in the colon, same in the stomach.
Sure. And Ryan, coming to you, would you advocate sort of adjuncts like transparent caps? Is that something you do in your regular practice, or is that just on a case-by-case basis?
Yeah, look, Vinny, I think I echo a lot of what Mike said, and that was a really good demonstration. I think what we're trying to advocate here is consistency, is find something that works for you, invest in understanding your technology. That was a Pentax-based system, whether you're using Olympus or Fuji, understand what your endoscope is telling you. That's the white light image, the enhanced imaging, whether it's iScan, whether it's NBI, whatever the enhanced imaging modality is, whether it's dye-based chromoendoscopy. And if you invest some time in understanding the technology and what you're getting back from the screen, then the rest will follow. Washing is really, really important, using mucolytic agents, using N-acetylcysteine. I do use a distal attachment pretty regularly in my practice, although my practice is probably a little bit more swayed in terms of neoplasia-rich cases. I think it helps to focus in, especially around the gastric folds, when you want to just lay them open just to make sure that you're not missing any subtle areas. But I think Barrett's surveillance, we've still got a long way to go. There is data from a few years ago that shows that it is done indifferently, and there is a miss rate, and there is up to 20% risk of incident cancers within the first 12 years of surveillance, and that needs to make us all look at our practice. What are we doing? It's similar to the colon, and how do we improve our ADRs? And we've gone through great lengths in the last 10 years to show that if we prep the patients well, if we use adjuncts to open up the colonic folds, we improve ADRs and we change outcomes. And so we've still got to go on that journey in Barrett's, and we're getting there. But all of the things we've just talked about, everyone should just take 1 or 2 bits from this morning's session and implement that into their practice, and you'll see the difference.
And I think we will obviously talk about AI and other sort of imaging tools as the course evolves during the day. But as you say, coming back to basics is really critical for any of these platforms to help us. And I think what's important for me, just in terms of the index endoscopy, is critical, because we know that prevalent dysplasia is far higher than incident dysplasia in Barrett's. So that first endoscopy is so important for that patient, because that will really map out the journey in the future. So if you had 3 tips, Mike, to give a trainee how to improve your dysplasia detection in Barrett's, what are your top 3 tips?
Yeah. So really simple. Spend enough time, that 1 minute per centimeter segment. Wash really well, get rid of all the bubbles, get rid of the mucus, whether you use, just a good water jet or a mucolytic like an acetylcysteine. Typically for most cases, I just wash really well. If it's just a regular index screening or surveillance for Barrett's, I just use the water jet, get rid of the foam and the mucus. And then use the tools that you have available to you. Most of us have some sort of optical enhancement feature on our endoscopes. So I'll do one good examination with white light, and then I'll use, in our case, we use Olympus, so I'll use a narrowband imaging. So, and that doesn't take, we're talking about a minute for a centimeter. And if you do that twice, with white light and NBI, or even technically, if you do 30 seconds with white light and 30 seconds with the NBI per segment per centimeter. So, really simple measures. And then target your biopsy to the first lesions you see, and then complete with your random biopsies.
And it's brilliant having all these tools like virtual coma endoscopy around, but what do people need to look for? It's great to turn these on, but what should they be looking for?
Yeah, and I think that it's all about going back to basics. Endoscopy is really straightforward. Whether you're in the colon, in the stomach, in the esophagus, what you're looking at two things. You're looking at the mucosal patterns, and especially in the esophagus, you're looking at vascular patterns. And it's just familiarizing yourself with what normal looks like David Graham showed there. Normal columnar metaplastic Barrett's I used to call it, if you remember when we were doing these, brain matter. It's nice and regular, sort of tubular villus type ridges. And anything that doesn't look like that should catch your eye. So if there's friability, of course, nodularity, if there's areas that are a little bit more hypervascular, if you've got areas that are amorphous or irregular. So they're the areas, as Mike said, that you need to target your biopsies, because that's where we know that you're most likely to pick up dysplasia. But we're still, much to everyone's annoyance, we're not at this stage yet where I think that, we can give up 4-quadrant biopsies, because, the technology, although not far off meeting PV with some of the optical technologies, we've still got a way to go before we've got a robust sampling modality that can target biopsy. So we still do need to take our 4-quadrant biopsies, as disheartening as that must sound to a lot of the fellows and nurse practitioners who do this.
Yeah, and we've talked a lot about endoscopy here, but Mike, is there anything when you're doing your Barrett's assessment, particularly your index assessment, is there anything that kind of makes that patient stand out as high risk for you? Things like gender or Barrett's segment length, are these things that are relevant, or are they irrelevant?
Yeah, so the risk factors for both Barrett's and for neoplasia within Barrett's are similar. Male, gender, any Caucasian ethnicity or race. Obesity is a risk factor, and length of Barrett's. Those individuals, I'm probably going to take that extra. We try to look carefully in everybody, but if you're going to choose somebody to really spend extra time, it's going to be that person. Yeah. Realistically, if you've got an endoscope in there, you've already committed to a screening or surveillance exam. We should do a complete examination on everybody that you've decided to do endoscopy.
And David there demonstrated quite nicely how useful acetic acid can be. Is this something that you adopt into your regular practice for all patients, or is it on a case-by-case basis?
I'm sorry?
The acetic acid. Is that something you do for everybody?
That varies a little bit. We don't typically use acetic acid. It actually happens to be a relatively good mucolytic agent too. So if you don't have an acetylcysteine available to you, I don't typically use it. I know there's variation across the world. I think we're going to hear from Oliver. That the practice that came out of Wiesbaden, really pioneered the use of acetic acid. It does work well. It's inexpensive, but I think the optical systems we have are likely of similar quality if you wash well and remove mucus.
Yeah, and Rayhan, you have a bit of experience in zoom endoscopy and magnification. Do you see that there being a role for that in routine Barrett's assessment, or is that more guiding you when you're doing your therapy? Because we're a little bit skewed in our practice, all three of us, but what are your thoughts on that?
Yeah, look, I think magnification endoscopy is something that we've borrowed from the East, where they've done that, exceptionally, especially in squamous dysplasia. I don't think there's a role, in my opinion, for magnification endoscopy in routine Barrett's surveillance. I think that magnification endoscopy, first of all, there is a learning curve, and is more based on experts like yourself in terms of defining lesions in terms of looking at depth of invasion, but also looking at delineating lesions before endoresection. So I think that, of course, that we shouldn't shy away from encouraging people to invest in learning, but I don't see a role for it in routine Barrett's assessment, although it may have a role in its the sibling, which is squamous neoplasia, where I think it's important that magnification endoscopy plays a critical role in the assessment.
Yeah, and look, I think the three of us could spend all morning talking about Barrett's assessment and how we can get better at it. We've done a lot of good work, but it's still a work in progress that's evolving. And Rayhan, that leads on very nicely to our next case, which will be kind of turning the tide slightly and moving further east and looking at squamous assessment and ESCN. So we're going to present a case here, Rayhan, that you've done recently, and kind of some tips and tricks for squamous assessment. I'll hand over to you, Rayhan.
Thanks, Vinny. So this is a 7-year-old lady referred for assessment of a random biopsy showing squamous dysplasia. It's a slightly older clip, so I'm using the Olympus 290 gastroscope and an Olympus distal attachment. I quite like to use a softer distal attachment for the assessment, so the Olympus distal attachments are a little slightly more flaccid compared to the more rigid distal attachments, and we're going to be using some enhanced imaging and magnification. So if we can go to the clip, so I can't see the clip, I can just see the slide. There we go. So this actually played real time. So you can see here I've got a distal attachment that is quite shallow, it is important to spend, there's a really nice review on distal attachment in World Journal of Gastro a few months ago, which I found really helpful in terms of what the different lengths are, and it's important to get to know that in terms of what the usability is here. So you can see at first glance with white light endoscopy, there's really not very much to see here, which is often the case with squamous dysplasia. So what you're looking for really is asymmetry. You're looking for little random areas of what might appear like candidiasis in the mid-esophagus, which is unusual. So that should catch your eye. Is there something that may be there? You're looking for asymmetry in the peristalsis of the esophageal wall. If you're looking at one wall which is peristalsing and the contralateral wall perhaps looks a bit more rigid. So you'll just begin to note here in the 3 o'clock position, something has caught my eye because there's almost a sort of white patch, and you'll see that just beginning to appear here, that then just takes your eye to an area of interest. It's really important if you're going to be using a distal attachment. Sorry, it's on the contralateral wall at 9 o'clock. You can see it almost looks like a bit of random candidiasis, which shouldn't happen in the mid-esophagus. Candidiasis should be a bit more widespread. So now I'm going to just try and get a little bit more information here. Again, just sticking to basics. I'm using my filter here and putting on some NBI, and all of a sudden you begin to appreciate on that posterior sort of left wall, there's perhaps a little bit of subtle nodularity, but there is a bit of a distinct darker tone to the vascularity. And this is where then you can begin to use your distal attachment to try and get some more information. So it's important that before you even start to go into the clever magnification is just do your basics right. And you can see here, just with a little bit of suction, I've isolated the area of question. And this is what you're looking for, ladies and gentlemen, in squamous dysplasia. You're looking at the vascularity. And you're looking for what we call intrapapillary capillary loops. So these are small vessels that come off the branching submucosal veins. And this is a really good example because if you look laterally, you can see the deep submucosal veins. And if you look right in the center of the picture, you can see these slightly, almost sort of horseshoe tadpole-like IPCLs. And these are indicative of squamous dysplasia because as you go through the different steps of inflammation to dysplasia, the initial part of the process is you get almost like an avascular sort of process. So these little blood vessels get isolated and they almost appear like you can see here, like little dots, little horseshoes, little isolated venules in the mucosa, which the distal attachment can see. As the cancer then becomes a little bit deeper and dives into that third layer of the mucosa and into the superficial submucosa, these blood vessels become engorged And there are various different classification patterns. The one that I personally like and the one that we've published in is the Japanese Endoscopy Society classification, which is quite simple, but there's lots of other ones. Haro Inoue described this first almost 20 years ago. So there's a very nice case, Vinny, of a subtle area of squamous dysplasia. Mike, I've got a real soft spot for squamous dysplasia, and I've invested a lot of time in trying to learn because it was a real unmet need in my armory. It's almost a sort of ugly duckling sometimes of squamous of esophageal neoplasia, because yes, we don't see as much of it as the East, but it's out there. Yeah. But it's very difficult. Any reflections on squamous neoplasia?
Yeah, I think we need to be very aware of this in what we consider Western countries. But the reality is the world has such high population movement that whatever country you're in, whether it's in the UK or for me in the Middle East or in the United States, you have a population that is at high risk. It's been clearly shown that first-generation Southeast Asian immigrants into a Western country have a similar or same incidence of squamous cell carcinoma. That incidence starts to drop off with subsequent generations. But every country, particularly the UK, particularly where I live, both in the US and in the Middle East, you have a population that you should be thinking about. The other risk factors, unlike Barrett's, where you're really thinking about obesity, Caucasian males, here you really have to strongly take into consideration tobacco and alcohol use.
Yeah.
And other forms, in some countries of the world, they'll chew various products that are major risk factors. In Kenya, as you know well, drinking extremely hot chai is a risk factor because of likely the thermal injuries. So we need to be aware of this, and your case showed how subtle some of these things can be. You really have to look very carefully to see those.
Yeah, Mike, thanks. And the other cohort of patients is the head and neck patients. Yeah. So just sticking on squamous dysplasia, we looked at something a little bit more subspecialized there with the enhanced imaging, but chromoendoscopy, dye-based chromoendoscopy. Tell me a little bit about Lugol's and its use in squamous dysplasia, Vinny.
Yeah, so it can be a very sort of simple and useful adjunct in patients with whom you're making an assessment for squamous neoplasia. So it's a Lugol's chromoendoscopy. It's applied sprayed endoscopically down onto patients. A few cautions: you've got to be a little bit careful that there is a risk of chemical pneumonitis with it. So you've got to be a little bit more cautious when you're spraying, to not spray too high in the esophagus. And it's all about, you're looking for a lack of Lugol's voiding there, basically. So you're looking for areas where the Lugol is not uptaken as well, so dark patches. These can be useful for high-risk individuals that Mike has kind of highlighted there. And I also find that it worries me, a bit like you, squamous neoplasia is very subtle, very easy to overlook. And one tip and trick I give to a lot of trainees particularly is actually spend time when you're coming out and internally audit your detection of inlet patches. Because I've found that you should be seeing this in about 10% of patients. And for me, if I internally audit that myself, that's told me that if I'm making that benchmark, I'm actually looking carefully. And that's just a little tip and trick that I've kind of told trainees. I want you to be seeing 10% of inlet patches, because that tells me you're focusing. Because this is something that we're not very good at on this side of the world, and it's something we need to work harder on.
There you go, ladies and gentlemen. You've got a new KPI as of Vinny's inlet patch detection rate of 10%. But I think the take-home messages for me, one, it's know your high-risk populations, your head and neck cancer patients, for example, who are coming in for gastrostomy placement before or after head and neck chemoradiotherapy. And also, look for subtle pointers in the esophagus, in the mid-esophagus, isolated patches of candidiasis, asymmetry, friability, and just vascular abnormalities. Now, that sort of sets the scene really for our first lecture. We know that imaging is really the integral part in how we shape the therapy, and we're going to later on this morning and in the early parts this afternoon talk about ablation, talk about resection. But every time I go on to PubMed, or I open one of our endoscopy journals, they are new studies that just keep on blowing my mind on how we can improve detection, not just in the esophagus, but in the stomach and in the colorectum. So no better person than Mike Wallace, editor-in-chief of GI Endoscopy, really to give us a whistle-stop tour of the advances in imaging modalities for Barrett's. So Mike, over to you, and really excited to hear your talk.
Good. Well, I'll give you a little bit of a historical talk here, because when I was a second-year GI fellow looking for my first project to work on, at that time, Marcia Canto was publishing her first papers on methylene blue in Barrett's esophagus. We were working on tissue spectroscopy in Barrett's esophagus. And I've spent much of the last 25 years now with each new technology. We got high definition, then we got narrowband imaging, then we got optical coherence tomography, and now we have AI. So we have this cycle of waves of new technology, and we go through the detection rates, classification rates, does it improve outcomes? So I'm going to give you a very quick historical background, and then we'll jump into some of the AI issues. But you can see this slide deck here on the cover. You can see from white light to NBI to OCT to AI technology. These are my consulting related activities. So before we get into how we evaluate Barrett's, let's look at what we're trying to accomplish. Fundamentally, we're trying to do three things. We're trying to find those at risk of developing cancer, and particularly at a time when we can do some effective intervention that's minimally invasive and also allows population-based screening. We then want to risk stratify so that we can choose the right intervention. That may be do nothing, or low-level surveillance, to more intermediate surveillance, to what's really transformed in all of our lifetime, which is treatment. When I was a fellow, it was esophagectomy or surveillance. That was it. We were just starting to see photodynamic therapy at that time. And now the third issue is, how do we offer some minimally invasive, effective therapy? And this has been a game changer. Having an esophagectomy carries a 5 to 8% mortality rate and a 40 to 50% major morbidity rate. Nobody wants an esophagectomy. If we can do something to avoid that, we have made a major difference in people's lives. Much more so than avoiding a colectomy for a large colon polyp, although the rectum, you get a little more challenges there. But I think if you want to make a difference in people's lives, it's offer an endoscopic therapy for early neoplasia in the esophagus as an alternative to an esophagectomy, and they will forever be grateful to you. But this is a position statement that recently came out on what do we need to accomplish in AI. This is part of this sort of PIVI process. So, this is, I put the full descriptor up here, but if you just go to, what are the main things we want to accomplish? And so if you look at the bottom here, the primary outcome, we want to be able to detect that Barrett's is there, and then we want to subclassify it as non-dysplastic, low-grade, high-grade adenocarcinoma. This seems obvious. This is what we've tried to do with all of these related technologies, but it's important to define what we're trying to achieve with AI, as this same task force has previously done with chromo and optical technologies. I like this slide from 25 years ago from a colleague at Mayo Clinic, Alan Cameron. This was an autopsy study. And before we could map dysplasia and Barrett's with endoscopes, you had to map them at autopsy. And so these were esophagectomy specimens in people who, again, underwent esophagectomy for low-grade and even high-grade dysplasia. And he very precisely mapped the location. And so this is what we see now when you look through an endoscope. You see this variability. You see areas of normal Barrett's, metaplasia, low-grade, high-grade adenocarcinoma. So this is what we need to train our eyes and our endoscopes to see. But it's nice to go back to these data from 25 years ago on autopsy or resection studies, at least I should say, esophageal resection specimens, and see what a mosaic we're dealing with in Barrett's. And it's very patchy, but when we can see it, we can treat it. For much of the last 15 years now, there's been this process to say, how good does a technology have to be in this case for Barrett's, to avoid random biopsy. This is really the main goal. And the so-called PIVI process, that stands for Preservation and Incorporation of Valuable Endoscopic Innovations. I have to remind myself every time what PIVI stands for. It was a bit of a stretch to come up with a name that we could use regularly. But the threshold values that the ASG set back now more than 10 years ago were that we should be able to detect per patient sensitivity at least 90% for high-grade dysplasia, NPV of 98%, and that's in a screening and surveillance population with a specificity of 80%. And that NPV of 98% seems very high, but the reality is anybody who walks in your door who's getting a Barrett surveillance, actually their pretest probability of not having dysplasia is probably close to 98%. So if I just waved my magic wand hand and said you don't have dysplasia, I would probably be right 98% of the time. This is what we talked about earlier. This is the 1-minute rule. So this is Pratik Sharma and Dr. Gupta's paper that showed, this was withdrawal time in the esophagus. The longer you spend, the more dysplasia you will find. With a relative, they chose a 1-minute cutoff, but you can actually see that it's a linear relationship in the upper right-hand corner there. The longer you spend, the more dysplasia you will find, but at least 1 minute. But as with the colon, typically, as with ADR, the more adenomas you find, the more protective benefit you have, and that's likely true in Barrett's as well. So historically, the first really valuable technology we got was NBI, and these are just a picture from one of Jacques Bergman, and at the time his fellow Walter Koevers is now on faculty in the Netherlands, but he was a fellow with us doing many of these early NBI trials with Dr. Bergman. And this was, again, the first major technology that allowed us to start to see that mosaic, and then as you can see on the bottom, or on the far right, to actually resect those areas. So if we can see it, we can treat it in most cases, as long as it's not a deeply invasive lesion. And when we started doing meta-analyses of these technologies, this was one of my former fellows at the time, now actually I've been chairing the ASGE Standards of Practice Committee, Bashar Kumseya, showed that if you use any of these technologies, CE chromoendoscopy, VC virtual chromoendoscopy, which is all the optical techniques, you get about a 34% increase in the yield for dysplasia. So these technologies work. They're consistent. We have very strong data now from prospective cohort and randomized controlled trials that using these technologies will increase your yield for dysplasia. Do they meet the PIVI threshold? So there was an initial analysis of this about 10 years ago, and then a reanalysis of this more recently that basically showed that yes, they do in fact. So if you look in the red boxes here, the sensitivity for NBI, 90%, that met the PIVI threshold. Overall negative predictive value, 98%, that met the PIVI threshold. And specificity, 80%, met the PIVI threshold. So in expert hands, these technologies meet the threshold. But that's a big qualifier, in expert hands. And I think that's really where AI is going to be most beneficial. It takes the expert eye and puts it in a box that everybody can put in their endoscopy unit. So if we use it correctly, we can all have an expert looking over our shoulder. So, if we take the pre-AI era, we can say that the available technologies, NBI, BLI, even Chromo, do meet the PIVI thresholds. And so, 5 years ago, we were saying, how can we extend this expertise to all users? Now, Barrett's was actually sort of the second priority for AI. Everybody went for colon polyps first because that was the low-hanging fruit. And now we have AI systems we're using in our endoscopy lab. They've been proven in multiple randomized controlled trials to increase detection, reduce miss rates, et cetera. And we're just starting to see, for about 2 years now, we're starting to see the publication of these technologies. This was a nice review that Pratik Sharma and Cesare Hassan from Italy just published in Gastro towards the end of last year, and looked at what is the role of AI for esophageal neoplasia detection. It's the kind of things you would think about. It's improve navigation. So even in the colon, we have systems that tell you you're moving too fast, you didn't look behind this shadowed or fold area, you didn't retroflex, at the gastroesophageal junction, so it can tell you to do the right thing. Then it can detect those lesions. It can put green bounding boxes on areas it detects, and then it can classify those. Again, that may be most helpful where you've got either a deeply invasive cancer versus a resectable lesion, as opposed to low or high grade dysplasia, because we're going to treat those pretty similarly. And then it can help you demarcate the lesion to say this is the area that's you need to look at. That very nice squamous case that Rehan showed. Again, pretty tough to demarcate that without a very, very careful inspection, but AI potentially can do that, and it actually can even look at the tissue after you've resected it to make sure you've got a complete resection. So fortunately, we've got pretty robust data now for AI and esophageal neoplasia, both squamous cell. This is some of the squamous cell, 3 of the larger squamous cell trials from that summary Sharma and Hassan article. So one thing to note here, though, is that when you read these papers, you see 10,000 images, but you have to read carefully that those 10,000 images come from 55 patients. So the numbers seem really big until you jump down, because remember, we collect 60 frames per second when we do an endoscopy, so you can get a lot of images pretty quickly, and those images are not necessarily all independent of each other. So when we train them, we really need to train them on a large number of patients as well as a large number of images. So we're starting to see now meta-analyses. So again, this one from many of the experts in the field, including Mario Dinas-Ribeiro, Cesare, Helmut Messmann, Pratik Sharma. This is a laundry list of the world's experts in Barrett's esophagus. And you can see that if you look at all forms of early GI neoplasia, and this actually also included squamous cell and early gastric cancer, I should say, the sensitivity and specificity were good. They met the PIVI thresholds. The NPV was lower, 91%, but with the caveat that negative predictive value is highly, highly driven by the patient population that you're starting with. If you start with a general screening and surveillance population that already has only a 1 or 2% chance of finding dysplasia, your NPV is going to be very high. In most of these studies, these populations were enriched with people referred for dysplasia, and thus the NPV wasn't quite at the PIVI threshold. And interestingly, these systems worked equally well for Barrett's, early squamous cell, and early gastric adenocarcinoma. So similar across the field. This was also another meta-analysis published in GIE just about the same time and came to very, very similar conclusions. You can see in the red box there on the left, sensitivity 94, specificity 88, very, very similar numbers to the other meta-analysis that I just showed you. So we've got 2 large meta-analyses, obviously most of these with overlapping trials that come to the agreement that the sensitivity and specificity are good. One of the things that we talked about is so much of this really depends on the population you're looking at. This is a classic graph that you'll see if you take an epidemiology course, and how do you assess sensitivity, specificity, NPV, and PPV. It's so dependent on your pre-test or prior probability. So shown here on the horizontal axis is the prior probability. So in this case, you're taking a Barrett's patient, and I've shown 2 examples. On the left-hand side is your regular surveillance patient who maybe has a 1 or 2 or 3% chance of having dysplasia. If that patient has a positive test, you go to the upper line, and now they only have a 20% chance that that lesion is actually dysplasia. So positive predictive value still remains low if you start with a low pre-test probability. But a negative test is highly, highly valuable in that group. But if it's a patient referred to you with a biopsy that said, indefinite, maybe low-grade dysplasia, then you've got a high pre-test probability, let's say 70% in this case. So in this case, a negative test still only gets you down to, maybe 15 or 20% probability. It doesn't rule out the disease, whereas a positive test gets you to a very high, in this case, about 95%. So always take into account the population that you're looking at. In a screening population, a negative test is really helpful. You arguably don't need to take biopsies there. In a referred population, a positive test is most helpful. This is, I wanted to pick a couple of the studies that were part of those meta-analyses. So this is a study, again, from Jacques Bergman's group in Amsterdam, looking at the algorithm they developed for AI. And you can see the so-called receiver operating characteristic curves. This is the plot between the false positive rate and the true positive rate as you vary the threshold of what you call positive or not. This is a standard way of assessing this. And the standard measure of accuracy is the so-called area under the curve. Because this plot is essentially a 1-by-1 box, and a perfect test rises vertically to the left upper corner and then goes across the top, essentially 100% specificity and sensitivity, that would have an area under that curve of 1.0. So essentially an area under the curve of 0.87 or 0.88 or 0.92, as you see here, is very, very good and roughly corresponds to the overall accuracy, 87, 88, 92%. But overall, we have good accuracy for these algorithms. These are some of the details from another study from Jason Samarasena's group in the United States and California. And again, they looked at, does it help, is it different if you use a white light based image, NBI, standard focus, near focus, or all of the above? And the reality is it doesn't. These systems seem to be trained to detect early Barrett's neoplasia, regardless of whether you're using your white light or NBI. You can see the sensitivity and specificities were pretty similar across the spectrum of those. This is a video, and let's see if, I may need our AV crew to click on this. I thought it was going to play automatically, but I don't think I can click on the video. So I'm going to ask our AV team, just back up one slide and click the mouse on the video there, and then the play button. So this is from the Bergman study, and what you can see here again is this careful examination, and most of these systems are using the same format, a green bounding box. Now, arguably, if you're the cynic in the room, you would say, well, I can see that without the green bounding box. And obviously the endoscopist is focusing on that area. In fact, they're in near focus mode in the area of interest, and the box is showing up. But what we're trying to do is put expertise in everybody's hands so that you don't necessarily need that box. And you can see here this sharply demarcated area that's different than the rest. And back to the original question, what are we looking for? The simple answer is you're looking for areas that are different than the rest. This area's got a little bit of mucosal and vascular irregularity. There's actually a slightly raised or nodular area right at the very top segment here at about 1 o'clock. And there's a sharp demarcation between this area, obviously against the squamous area. Now this is a more normal area of non-dysplastic Barrett's. But the technology here is doing what we see in the colon. It's putting a box around the area of interest and saying, look here, look carefully. And that's really all it does. Once you have the box there, we just go back to the look here, look carefully modalities. I'll just put in a quick word. This technology actually is no longer available, but it's the so-called volumetric laser endomicroscopy. This is a good example of where we really needed AI because we had huge data sets to look at and relatively subtle features that we as endoscopists weren't used to looking at, like these white little patches that were glands, loss of layering architecture, and dark surfaces. So it was a new technology, but you could train AI algorithms to classify this. So we didn't need to teach everybody a new system. You could simply train the AI algorithm to classify these. And in this technology, again, it worked quite well. It was quite helpful at classifying these scans here. And here's, again, just the way it was displayed in this area is hot spots. And so these areas actually in real time, you can mark these and then go back with your regular endoscope. It puts a little cautery dot on that spot corresponding to where the balloon catheter system saw the dysplasia. So just to summarize, back to basics is the key message, I think, of the day. Advances in Barrett's imaging have allowed us to do complete endoscopic therapy for early neoplasia, including intramucosal carcinoma, and has replaced surgery as the standard of care in my lifetime, in my career, and that's been a game changer. The current tools that we have up until we had AI, and I didn't get a chance to go into some of the non-biopsy based Watts or even brush systems, all seem to work well and in fact meet the current PIVI standards in expert hands. We've got new technologies, even non-endoscopic technologies, the cytological sponge, even the so-called tethered-based capsule endomicroscopy systems, which I didn't have a chance to show today. But I think for our purposes today, the AI systems are approaching human-level accuracy. At least in the meta-analysis, they didn't reach PEVI thresholds because of that negative predictive issue. But again, the caveat that they had these enriched populations and it's hard to reach high NPVs in a population that's got a lot of dysplasia to begin with. So very happy to be here today. This is my email address. If there are any follow-up questions, happy to answer those today or offline.
Excellent talk and a great overview, Mike. Thank you so much for that. What do you think are the next steps and the biggest challenges with getting AI into the upper GI tract in Barrett's? What would you say that is?
Yeah, so clearly, fortunately, we have a paradigm for polyps that we followed. So polyps being the low-hanging fruit. We went through this phase of, can we train the algorithms? How well do they work in enriched populations? We're just now getting to the randomized trials of standard imaging versus standard imaging plus AI. Colonoscopy got there because of 2 large international randomized controlled trials that went to get on CE mark and get FDA approval. And now, as of last year, those are available worldwide essentially. We're not there yet with Barrett's, but that's the pathway. So we need to get to large-scale randomized controlled trials of best-in-class standard imaging, which I would say is certainly high definition with some sort of optical enhancement, versus that with AI.
Sure. So in the interest of time, what we're going to do, Ryan, is we're going to demonstrate your case now, where you've used an AI system to detect dysplasia in Barrett's, and then we'll kind of do a Q&A after the video to really go through a bit more detail regarding what we've talked about.
Okay.
So if we can get the video ready on screen for Rehan to discuss.
So this is a piece of work that we've been involved in for the last 5 years with our colleagues at ONM Vision and Peter Mountain and his team, and actually congratulations to them for their new partnership with Olympus, which is really exciting. And so this is based on our Pentax system. So you can see here, first and foremost, the important thing is, I always say with AI in the esophagus is, garbage in, garbage out. So you need to clean, you need to do your basics right so that you can give the algorithm, you can give the box every chance to help you. Now this is a pretty obvious lesion, but we're just going to, because this was a case that we did just a few weeks ago. So you can see this is someone with a long segment of Barrett's esophagus, and you can use, as Mike showed in that nice review by Pratik and Cesares, you can ask the box different questions. This is less so about where am I going to take a biopsy, because we can all see there is dysplasia on the posterior wall, and our AI system has just helped me. But actually what I might be asking the box here is, where shall I place my delineation marks? Because I'm going to do a large-scale ESD here, or endoscopic mucosal resection. Help me to differentiate between what's normal and abnormal. And in that context, this is where this is quite helpful, because all of a sudden, I have dysplasia on the contralateral wall that I had not seen. So from being a hemicircumferential resection, all of a sudden this becomes a circumferential resection. And you can see here, all of these images that are being interpreted are all in high definition white light endoscopy. There's no enhanced imaging, there's no optical chromoscopy. There's a bit of friability there from the cap, which unfortunately is part of the course. So there is a very short but real-time demonstration of what we've been working on and publishing on, and NASA, who's our fellow, is now doing exactly what Mike has challenged us to do, is to follow the roadmap that the folks did with colorectal polyps. We need high volume level 1 evidence to show that these systems will work, not just in enriched populations, but also in a surveillance population. I get challenged about that by the text to say, well, actually, do you? Will we see AI in Barrett's, whether it's through Olympus, Pentax, Fuji, hit prime time in our suites without level 1 evidence? Do you think we can get there, or do you think we really need to invest a bit of academic time in shaping these studies? Because to power these studies is completely different from powering the colorectal studies.
Yeah, it's we've been through this with a number of technologies, at least with the FDA. I chaired the group that went to the FDA for the colon polyp trials, and they are tough. They want to see 2 large randomized controlled trials showing benefit, and they want a realistic control arm. And in this case, when you're comparing it against, let's say, NBI or iScan, that control arm's already pretty good. So it's a tough nut to crack, so to speak. One question I have for you, in that case, Barrett's to me, I think about differently than colon polyps. Colon polyps are a discrete lesion in a background of normal mucosa. In Barrett's, once you find dysplasia, the next step is, as you said, what am I going to resect? Now, realistically, what we have to resect versus ablate, we're going to ablate the whole Barrett's no matter what, but we really need to resect the cancers. And so I don't necessarily care if there's a little bit of flat low-grade dysplasia on the opposite wall. I want to make sure I get the cancer out, the nodular disease out. Yeah. So how do you deal with that in AI? Because a good system is going to say, well, first it's going to flag all dysplasia and target biopsies. But in this case, you have that subtle lesion on the left wall, that pretty bulky, stiff lesion on the right wall.
Mike, and this is the sort of confounding that these systems begin to introduce into your decision making in real time, because the longer you looked at that lesion, the more invasive and the more horrible it got. Yeah. You're absolutely right that the paradigm for treating Barrett's dysplasia has still got ablation at the end of it. And I think that certainly the last 5 years with endoresection, endoscopic submucosal resection becoming so popular, and to some extent probably not with a robust evidence base, we've perhaps swung the other way a little bit because we've become so resection heavy. But you're absolutely right. In that case, I suppose it was just to showcase that there was a bit of metachronous dysplasia, but you still want to go back to basics, and we'll talk about this in the next session, which is resect the cancer, and don't forget that you've still got ablation, which will get rid of that flat dysplasia. Really good point. Vinny, we talked a little bit about the AI systems in Barrett's, but in terms of workflows, it's all very well talking about this in theory, and in terms of sort of implementing this into workflows, you've done it at UCH, bringing this into our surveillance list. What are the challenges there to not get a Vinay or a Mike to train on these systems? How does the average endoscopist, like a fellow or a nurse endoscopist who's doing high volume surveillance work, how do they implement this into their workflow? What's the learning curve?
Yeah, so I think it's really interesting, and one of my questions I was going to put to Mike was about training. What does AI do with training for us? Does it support training, or does it hinder training? And as you alluded to in the dysplasia case just there, is this something that experts need, or is it just for non-experts that need it? And I think these are some unanswered questions, actually, and the studies will hopefully help through that, and the control arms, like you said, are really important. But I think it comes back to basics, and we've said this over again, a bit of a broken record. We need to be investing the time. We need to be really clearing out the esophagus so we can see clearly, and give the system an opportunity. And you've got to invest in that time and that energy. Mike, there was something I noticed in your talk about the number of images used. So there's a lot of still images. Do you think that's a limitation of all of these studies? Because we're now extrapolating still images into live endoscopic videos. What are your thoughts on that? Is that something that needs to be worked upon?
Well, in essence, a video is 60 still images shown in 1 second. So still image videos are fundamentally a lot of still images. The key is that 60 frames per second are not independent. And so when we have to think about how we do statistics and how we develop these algorithms, it's different if you have 2 different patients versus 2 images on the same patient. And so you can model this if you use the same images over and over again. Now there's limitations. We just sometimes don't have enough patients, and there's lots of little tricks in the trade of how to do that. There's something called adversarial neural networks, where you take the same image and you blur it, you twist it, you flip it, you throw another, bunny or car or something in the image to try to trick it. You make it adversarial. But at the end of the day, the expectation, when we come back to regulatory approval, is that these systems be based on a number of patients, not the number of images. But when we're starting this research, we take the limited patients we have. We often have lots of images in those same patients, and it's a reasonable starting point.
Brilliant. So I think we're going to move on to the next session now. And we're joined by Ollie Peck from Germany and Arjen Kok from the Netherlands. And the focus of the next session now will be on sampling, resection and staging of esophageal cancer. So hi Ollie.
Hi.
Great to have you here. And hi Arjen.
Hi.
Thank you for joining us. We've got a really great session lined up now, and what I'm going to do, just to begin with in the interest of time, is we're going to play Ollie's talk on endoscopic resection, and specifically, is there still a role for endoscopic mucosal resection in Barrett's related esophageal cancer? So if we can go to the talk, please.
Hello, dear colleagues. I would like to talk about endoscopic resection in esophageal neoplasia and cover the topic if there's still a role for piecemeal resection. So I want to talk about two different types of Barrett's, two different types of esophageal neoplasia. The Barrett's neoplasia, here an adenocarcinoma, or the squamous cell cancers. I would like to start with the squamous cell cancers. So regarding the endoscopic resection in squamous cell cancers, we don't have much data. There are no prospective randomized data comparing ESD with piecemeal EMR in squamous cell cancer, and there are prospective series of on EMR of squamous cell cancer, and those show some quite high recurrence rate of up to 25%. Retrospective studies demonstrate also a higher complete resection rate with ESD and a lower recurrence rate with ESD compared to those patients who had a treatment with piecemeal EMR. So this is what we have. Therefore, the current guidelines that were published last year on ESD in esophageal cancer said that ESD is the treatment of choice for squamous cell cancer to provide an oblong and potentially curative resection. And ESD should also be considered for oblong resection for those patients who have a more advanced early squamous cell cancer, like those with T1A M3 and those with SM1 situation and without a circumferential lesion, and for those also who have a circumferential lesion that are clinically staged as T1A, M1 or M2. So those are the recommendations regarding the squamous cell cancer and endoscopic resection. So there is no place for piecemeal EMR in SCC anymore. Those are the recommendations in a flow chart. So we start with endoscopic diagnosis. We engage virtual endoscopy, chromendoscopy, and then have a look at the different types of vessels. We just heard about that in the last session. So when we don't have signs for deep infiltration with vessel type A and type B1, then we should perform an ESD. When we have signs for more advanced T1 cancer with type B2 vessels, and then we should consider to perform an EUS for staging and perhaps a PET-CT. When we don't find any signs for deeper infiltration or for metastasis, we can perform an ESD. Those are considered to have to be expanded indications. And when you have M3 situation and or an SM1 situation and it's a circumferential lesion, also those patients have a very, very low chance for a curative ESD. Those should be sent for chemoradiotherapy or surgery. And those who have signs for deeper infiltration like SM2 should be sent for chemoradiotherapy or surgery directly. So in the next part, I want to talk about Barrett's neoplasia. This is a little bit more complex. So we have two treatment techniques for two resection techniques. We have the multiband endoscopic resection, and we have the ESD. So this is a case from last week from my center. So you can see long segment Barrett's esophagus with irregular mucosa, bumpy, and it's quite difficult to really delineate where the borders of the lesions are. So we really had a close look with chrome endoscopy, magnification endoscopy, and then we performed an endoscopic resection. And I think when you have a look here, most of you would think this was an ESD, but we performed an MBM, so piecemeal resection with multiband, and at the end it looked like that. So a complete resection of the lesion with really no islands in between and clear margins here. So this is how our piecemeal resection can look like at the end when it's done properly. What are the data for piecemeal resection? Those data are from our center with 1,000 patients with intramucosal adenocarcinoma, all treated with endoscopic resection, mostly piecemeal resection. We achieved a complete remission rate of 96%. We had a recurrence rate of 14% because in the initial phase, we started to include patients 1996. So in the initial phase, we did not perform ablation after endoscopic resection. That's why we had a quite high recurrence rate or rate of metachronous lesions. At the end, we only had a rate of recurrence or metachronous lesions of less than 5%. Retreatment was possible in most of the cases, and therefore long-term complete remission rate was very high with almost 94% after 55 months. So very good data for conventional piecemeal EMR in early Barrett's cancer. We should follow the two-step strategy, which was investigated in the Euro-2 trial. 132 patients were with high-grade dysplasia and early Barrett's cancer were included in 13 European centers. Step 1 was endoscopic resection of all visible lesions, and step 2 was radiofrequency ablation of the remaining Barrett's esophagus. Complete remission of neoplasia was achieved in 98% and of Barrett's esophagus in 93%. And there were only 5 recurrences of high-grade dysplasia and Barrett's cancer, and all those were retreated endoscopically. The recurrence rate here was 3.8% in this study. So excellent results in expert centers when you follow the two-step strategy of piecemeal EMR followed by RFA. Are there any data for ESD versus EMR? There's only one small prospective randomized trial. Horst Neuhaus in Düsseldorf and his group included 40 patients with high-grade dysplasia and early cancer, and they, with 20 in the EMR group and 20 in the ESD group. As you can see, our zero resection rate was significantly lower in the EMR group than the ESD group, of course. But when you have a look at the complete remission rate of neoplasia, both groups were similar. So there was no significant difference between both groups regarding the complete remission rate of neoplasia. So why is it like that? Why is there is a difference between squamous cell cancer and Barrett's cancer when you perform ESD or piecemeal EMR? So this is the Barrett's cancer, this is the Barrett's esophagus, and you have multifocal lesions very often in a long segment Barrett's esophagus. You might have one cancerous lesions and then high-grade dysplasia here, high-grade dysplasia here, and low-grade here and low-grade here. In squamous cell cancer, it's usually much easier to delineate the lesion and you have your cancer here. So when you perform then an ESD, for example, in Barrett's, you very often have an R1 resection because it was quite hard to delineate the lesion, and you have multifocal lesions. So you might cut through an high-grade dysplasia or low-grade dysplasia you did not visualize on your endoscopic imaging. With squamous cell cancer, it's much easier to delineate the lesion, and then therefore the results for ESD are much better. When you perform a piecemeal resection, like here or here, you might leave back one residual cancer here, and therefore you have a recurrence. When you leave back here in the Barrett's, high-grade dysplasia, low-grade dysplasia, and you removed most of the cancerous lesions, but you still have an R1 resection here, for example, for high-grade dysplasia, and left some high-grade dysplasia and low-grade dysplasia in the Barrett's, then you can still perform RFA, and then you ablate the residual neoplastic lesions, and therefore you achieve complete remission long-term. There are also some other studies, retrospective cohort studies from other centers comparing EMR and ESD, and this is always the problem with those retrospective studies. The patients, 456 patients here were included who were treated with piecemeal EMR, and 81 with ESD. Of course, those were the patients with EMR treated many years ago, and in recent years, patients were included in the ESD group. Results were as follows. After 2 years of follow-up, there were more patients in complete remission in the ESD group compared to the EMR group, 85% versus 75%. And when they did the calculation, independent factors to achieve complete remission of dysplasia or cancer were performing in ESD, or when the patient had a short segment Barrett's esophagus. Similar results were shown in this meta-analysis of 22 studies with 2,752 patients, 1,419 in the ESD group and 1,219 in the EMR group. Included were patients with Barrett's cancer and squamous cell cancer, and the outcome was a block resection, curative resection, R0 resection, and local recurrence rate, and ESD was superior to EMR in lesions larger than 20 millimeters, which is not surprising, especially because in this study also patients with squamous cell cancer were included. But ESD and EMR were equally effective in smaller lesions, up to 20 millimeters in diameter. And there was a recently published paper from the US with a retrospective cohort study, again, 8 academic centers. They compared 243 patients, 150 had an EMR, and 903 were treated with ESD. Patients with Barrett's adenocarcinoma were included, and after quite short follow-up, they showed that there was a significant difference in the R0 resection. Here in the EMR group, we had only 56% of R0 resections, and in the ESD group, 73%. And there was also a significant difference in the recurrence rate and whether an additional recurrent endoscopic resection was needed in the follow-up. So you can see here in this study that ESD was superior regarding the recurrence rate and whether an additional treatment was necessary. So what do the guidelines say? The ESD guidelines from last year say the following: when you have a flat lesion, which is smaller than 2 centimeters in diameter, and you don't have any signs of submucosal invasion, you can perform an band-assisted mucosectomy like the MBM I showed you in the pictures. And you can also perform an EMR, piecemeal EMR, when you have a larger multifocal dysplastic lesions. So no cancer larger than 20 millimeters also can be treated with EMR. When you have a suspicion for submucosal invasion, for example, Paris 1S, or when there is a type 2C component in the lesion, or when it's cancer larger than 2 centimeters, or when you have fibrosis or scarring, then you should perform an ESD. After endoscopic resection, you should ablate all the remaining non-dysplastic Barrett's mucosa. When you have suspicion for deep invasion, of course, complete staging and then surgery. So for example, this here, you can see a lesion here, which is quite bulky. When you have a closer look, there's also even a small ulceration in there. When you switch on your NBI, you can see there are also pathologic vessels. So this is clearly not a lesion for a piecemeal EMR, and you should perform an ESD like we did here in this case. So I would like to come to an end. So is there still a role for piecemeal resection in ON? In squamous cell cancer, no, there's no place for piecemeal resection anymore. In Barrett's neoplasia, yes, for flat lesions without any signs for submucosal invasion up to 20 millimeters, and for large or multifocal dysplastic lesions. Thank you very much.
So hello, good morning everyone. I've taken the hot seat from Vinay Sehgal. My name's David Graham. I'm also a gastroenterologist at UCH, and as he's already introduced, we're delighted to be joined by Ollie, Arjun and Marnix Janssen has just joined us classically on time as always. Marnix, beautifully done, well done. And we're still here with Mike and Rayhan. So Ollie, fantastic lecture. Thank you so much. One thing I always not struggle with, but have questions about is we know that the data on successful endoscopic treatment of Barrett's neoplasia, for example, with resection and ablation has been hugely successful. The data for long-term outcomes is really, really good. And all of that data is based on EMR. So what is this drive to then suddenly say, do you know what, guys, the 97%, that's not good enough. We want more. What is the drive now to change to ESD?
Yeah, that's a very good question. So the problem is with those larger lesions, when you have a bulky larger lesion and you can't really get the lesion into the cap of your resection device for like the MBM. So it's quite difficult to perform this piecemeal resection in such a lesion, and you really cut through the bulky lesion. So it's better for the pathologist when you have one big lesion that with an oblong resection to really assess the infiltration depth and if there are any lymph vessels involved or other vessels involved. So for the pathologist, and we might hear Marnix's opinion on that, but at least what my pathologists tell me is that it's much better for them to have one single lesion, especially for those big bulky lesions, but for those flat lesions, I think it's no problem to perform a piecemeal EMR, as I said.
So much actually about the complexity of the resection. It's more for our pathologists to be able to give us the accurate prognostic way forward. So Marnix, does that ring true with you? What are the problems with piecemeal resection from your point of view?
Yeah, absolutely. Dave, I can only echo what Ollie has just said. Obviously, the more margins you have your problems compound. And on top of that, it's also true that larger specimens are often slightly easier to work up because there will be less floating of your tissue slices within the cassettes, which also then reduces the risk that you might have cross-cutting into these specimens, which gives us a better vertical infiltration depth, right? Because the risk with cross-cutting, of course, is that you start measuring diagonally and then artificially, spuriously measuring your infiltration depth. So clearly, absolutely, I'm with Ollie on this as well.
Brilliant, thank you very much. And Arjun, one thing that, focusing a bit on ESD work, but with EMR as well, one thing I found, and I think we've all found as a problem, is strictures following resections, particularly as, these lesions we're getting, I think, better endoscopically, and we're taking on bigger and bigger things we perhaps wouldn't have taken on before. And then these patients are coming back with really difficult to treat strictures. How do you manage these patients? What do you do about that?
Yes, thank you. First of all, nice presentation, Oliver. Really enjoyed that. And I think there is at the background, we have become more aggressive towards more advanced lesions that we might have referred for surgery in the past. So, of course, what you say is true. The data on piecemeal EMR are so good. So why introduce a technique that is far more difficult, like ESD? But this is partially because we are more aggressive towards more advanced lesions in endoscopic resection as well over the years. Of course, strictures are, most strictures I think are easy to treat with a few endoscopic dilations, and usually the stricture fades out and we're fine and we can proceed to RFA. But of course, we need something for these larger lesions where we do circumferential resections, etc. The stricture rates are high and they're usually tough to treat. So one of the new kids on the block, I think that we are currently investigating in a randomized trial is the oral dispersible topical budesonide that has been used for eosinophilic esophagitis. And I think it's a very promising new drug. We know the data from the EOE, very good. And we have also been experimenting with that in larger resections in the esophagus, actually with very good results. So in this trial, and we are now somewhere in the middle, we're doing an interim analysis, and hopefully this will be in favor of the treatment arm. I think that the topical budesonide is something that might be promising in the future to treat, to prevent strictures. And if they do occur, then usually they are, in my opinion, they're easier to manage. So hopefully a new role for budesonide.
Fantastic. I mean, I think that would be, I think we've all had the few patients that have been very difficult to treat. So I think if that works, that'd be fantastic. Mike Rahan, coming to you in the studio. Clearly, as Arjun beautifully said there, we are taking on more aggressive lesions. Marnix and Ollie have talked about, submucosal lesion. How far can we endoscopically resect now? What's the thoughts on where do we stop?
So this boundary keeps moving. Largely, it's getting deeper and deeper is the bottom line. There is a difference between squamous cell and adenocarcinoma and Barrett's, and really we're talking about cancers only. Yeah. High-grade dysplasia, universally, we're going to treat with resection plus ablation. So when you have cancer, the general rule is squamous cell, what we're really trying to decide is there a risk of a lymphatic or other distant metastases that we have not treated? And that's predicted by the depth of invasion, various other factors, tumor budding, differentiation, lymphovascular invasion. So our goal is to resect lesions and then confirm that they are at low risk for lymphovascular invasion. The bottom line is the deeper you go, the higher that risk, the higher the grade, the higher that risk, the more lymphovascular invasion, the higher that risk. In the end, it's never 100% or zero. So it's always some gradation in there. For squamous cell, generally, once you get into the deeper mucosa, the risk of lymphatic metastases gets significantly higher, well over 10%. For Barrett's adenocarcinoma, there's a deeper threshold. So that risk of lymphatic metastases doesn't start to go significantly higher until you get into the superficial submucosa, and particularly the deeper submucosa. So generally speaking, for squamous cell, if it's into the deep mucosa, we start to get worried. Certainly into the submucosa, we're very worried. And for Barrett's, M3 or SM1 is generally our boundary. The caveat here is you always have to, we're assuming these are margin negative. If it's margin positive at the deep margin, that patient likely needs surgery. The difficult thing here is, we're often dealing with elderly, sick patients. You have a margin negative but high risk lesion, let's say an SM1 or SM2 Barrett's adenocarcinoma, but a negative margin. You've resected the primary, and now you're saying, should I send this patient for an esophagectomy and mediastinal lymph node dissection because there may be lymph nodes? Again, we've done a PET CT, there's no obvious. So this is a tough question, and I must say most of my patients in that situation now are opting for observation. And out of Japan and China, we're even seeing adjuvant therapy in this setting to prophylactically treat those high risk. That's really pushing the boundaries of our current algorithm.
I think that's really interesting. So where do you sit with this? What are the people you say, and I think we're doing similar to you, but what are the people you say, actually, gosh, I'm worried about your histology? What cutoffs do you have? We've seen the Dutch data a while ago, about their sort of cutoffs.
I think this is a big unmet need in terms of consensus in let's just stick to Barrett's cancer here. First of all, Ollie, great talk. Arjun, good to see you. Really nice to have you here. These two guys taught me how to do ESD, so it's your fault that we're having to have these discussions. But I think that I have three reflections here. First of all is we need to move away from an endoscopic decision. This is an oncological decision, and it mustn't be made in isolation. And I think we need to make this with a patient within an MDT. My second reflection is this is also a really data light field. We have some very good historic data, which as Marnix would allude to, I'm sure in the late. This is on historical surgical specimens or even historical endoscopic resection specimens, which they were cut differently. So we are advising our patients, we're prognosticating their risk of not luminal recurrence, as Mike said, extraluminal distant lymph node mets, based on data that may or may not be accurate. The third reflection is that we're still in the game of organ preservation here. We can't shy away from the fact that an esophagectomy is a big operation. So I think that we will be informed by the randomized study, the PREFER study that we're involved in, led out of Holland, but we are erring on the side of exactly as Mike said. These are senior patients, they're comorbid, vigilant surveillance with multimodal imaging, and perhaps, as Mike said, being even a little bit more proactive in younger patients with deeper cancers with higher risk stigmata, looking to engage the oncologist about adjuvant therapy. But it's a really data light field, and I think hopefully the next 5 years we'll get some really necessary information from this randomized trial that will shape what at the minute is a lot of anecdotal expert opinion.
So look, that's we've got plenty more time in this section to keep going with these discussions, but just for now we're going to go to a case. This is a patient who's undergone an EMR, and actually the case itself has been done by one of our excellent fellows, whilst Matthew Banks, who'll be here later, is teaching him how to do an EMR. So hopefully this is a great teaching case. So let's see that video.
So I'm Matthew Banks. I've got Ben with me today. This is a case of a long segment of Barrett's that was referred into University College London Hospital with a diagnosis of focal high-grade dysplasia. Use the cap to, you can see there, if you try and vote there, stop, okay, just where you were, okay. You can see that there's a strip of mucosa where there's no, there's an amorphous type appearance. We've got no surface pattern. no clear vascular pattern, and that's almost certainly dysplastic. There's also no squamous regeneration within that area, and that adds to the fact that this is almost certainly dysplastic. I can't tell whether it's high grade or low grade. So we are now going to EMR that area. So the first mark is the 2 or 3 millimeters distal to the lesion. So you just gently place it on, and we're using forced coag. Find yourself in a comfortable position. Okay. So this is a Cook Duet EMR kit. This is the device that is used to deploy the bands over the cap. This is a threading device. So once you've loaded it, I load it on top of the bung here because it creates a seal, so you can retain the gas. And then you need to puncture the top of the wheel, and then you place the deployment. Yeah, I've got, yeah. I'm gonna put the catheter through the scope. When it comes out here, there's a small hook through which you can put the string. There we are. Now you slowly put it back. Okay, and then the last bit, stop. Unwind it to make sure the strings unwound, and push it all the way down to the hilt. Put the lamp back on, and then slowly wind it round the wheel on. Yes, so it's not fixed. Remember, if you push here, it's freewheel, and then you push in, it's fixed. Now, this is pentax stop. Now your snare comes out at 5 o'clock on the pentax. So make sure that you've got space for the snare. So use this orientation, and then as you deploy the bands, it slowly moves clockwise. We don't need all of these bands, so to improve visibility, I want you to deploy one and a second. Good. And we've got 3, that's all we need now. We'll probably only need 1. Slowly angle the scope in, not too much, because then if you angle too much, you will not be able to suck up efficiently. And now try there, center of the lesion, try to suck that up into the center of the cap. And suck. Okay, keep sucking. Keep sucking. That's good. And relax the wheel a little bit as you suck. Slowly relax the wheel. And now, good. Now deploy. Good. Excellent. So now you need to hyperinsufflate. And the reason I hyperinsufflate is to ensure there is no muscle left within that pseudo polyp that was created with the band. So the next steps are to snare it off, and we will be using endocup Q, effect 3, and force coagulation 4.5. Endocup Q was designed for snaring, and it's a combination of a cut wave and a coagulation wave. So now always work at 6 o'clock. So when you put your snare out, you can gently place it over the band and make sure the tip is not buried within the mucosa beyond it. Okay, snare out, please. Okay, so gently lower it over the lesion. That's it. I'm going to keep that slightly. Okay, use the scope to manipulate it over. That's right. And then start to push in. Insufflate because you can't see what you're doing. Try to bring it 6 o'clock. Bring it round 6 o'clock. Bring it round 6 o'clock. Bring it round 6 o'clock. Excellent. Keep bringing it round 6 o'clock. So I'm just pushing it out. Push the scope in as far down as you can. Push it underneath. Keep, there we go. There we go. Now start to close. Okay, so now what you want to make sure is that you are not gripping any mucosa or muscle. Okay, so try to elevate it very carefully, see what it feels like. Does it move quite easily? And the other point to make is whether there's any bounce on the snare. Is there any bounce on the snare? Okay, so it's nice and snug. So now what you don't want to do is if you push it up too much, you'll force the tip into the mucosa, which is what we don't want to do. So you need a nice relaxed position. Okay, plenty of insufflation. And now you're going to use cut. You can use cut or CAG. It doesn't matter. But what matters is how quickly it's closed. Tim's going to close it very slowly because we're going to use cut. Okay, and you can hear the cut wave, which is the ping, and between each cut wave is the coagulation wave. So as it cuts, you'll feel it go through. So you want to reduce the amount of deep thermal damage, but make sure that there's no bleeding. Now, are you ready? Click on pedal. Okay. When you start to cut, make sure it's nice and relaxed. So when we start to use cut, you need to tell Tim. He'll be able to hear it, and he'll slowly cut.
Okay, Tim. So we're going to be cutting now.
Good stop. Fantastic. Okay, beautiful. Now inspect your base. And make sure so you see there's no muscle layer there. No bleeding vessel. That was a beautifully performed EMR. And there's one, I'm not sure that those dots are, so we might need to do one more overlapping EMR.
Tim, we're going to use cut. So in 2 seconds. 1, 2, start cutting.
Lovely. Beautiful. Now, have a look at the base.
Hey, well, you just came in there with Mike commenting actually about how he approaches the resection slightly differently. So Mike was just saying actually he goes oral to anal side. Mike, why is that? Why do you do that? Just so there.
Just when you want to get that beautiful sort of clean resection like Ali showed at the beginning, you really want the edge of the second band to be at the edge of the last resection. When you go oral to anal, you can see the band right on the previous cut edge. When you go anal to oral, you can't see what's on the distal side of the band, and you can't ensure that it's grabbing the previous edge.
That makes sense.
That's a very small practical point, but it's
great. Arjun, coming to you. So there's another tip there for Mike. In terms of training, you obviously have people come through your unit, want to train in EMR. What are your sort of top tips in terms of numbers of procedures, but also what top tips you have for the procedure itself to give your trainees to try and limit, improve their resection rates and obviously limit complications?
Well, first of all, my approach is the same as Mike suggested. So I work from proximal to distal. I think that you can minimize the overlap, but still have sufficient overlap there and have larger resections. Working the other way around, actually, I've never done that. So I was a little bit surprised to see that. In numbers of training, well, I'm not sure I can put a number on how many procedures should be performed. But I think you can, if you train somebody, you will see how this learning curve develops. You can see how confident somebody is and how good he is in doing that. So I think on an individual basis, I would decide on when somebody is, ready for training and maybe ready for some kind of certification. So I don't want to put a number on that. I'm not sure about the other part of the questions.
Just your top tips in terms of when you're teaching your trainees, what are the things you want to make sure they focus on and to make sure they get a successful resection?
Yes. So we can start all the way from the basics. Is of course recognition and delineation of the lesion, which is I think the most important step. The banding in itself is not that difficult. So I always start at the most proximal end. The proximal marker is where I put the rim of the cap first. And I think one of the important things is then you angle the scope. Usually I angle it quite forcibly, but once the lesion is sucked in, I try to de-angle and pull back slightly, so a lot of mucosa can come into the cap and more from the distal part, and the rim of the cap prevents anything from being sucked in from the proximal side of the above the lesion. So you have large piece resections, and then aiming to place the snare indeed, as we saw here, under the rubber band. And one way of making that easier is trying to position your snare around the lesion already when opening, not when it's fully open, because then usually you find yourself in the narrow esophagus and it's sometimes hard to manipulate. So while opening the snare, already try to position around the lesion, and it's much easier to come underneath the rubber band. One other thing is usually I do not overinflate after the rubber band is placed. One of the things that I try not to do is that if you overinflate, this band might be pushed up a little bit, so your resection piece becomes smaller. So usually I do not overinflate until the snare is in position.
Fantastic, thank you. Really good tips, thank you. Ollie, I guess the most common thing that I think we all see when we're doing EMRs is bleeding. And I think there's a sort of a conception, we didn't see it in that clip obviously, but you know, there's sort of this perception perhaps that, oh, bleeding must be a problem, but actually it's very common to see bleeding after an EMR. You know, it might not be a huge spurting vessel, but you know, might get a bit of ooze you've got to deal with. How do you deal with bleeding? You know, what are your tips in terms of that? Do you always have to go straight in to treat it, or what do you do?
So bleeding is quite common. You have small vessels there that have shown oozing bleeding. What I usually do is you can use the tip of the cap to just push against the vessel, then it stops, and then you can wait a few seconds or half a minute, and then what I usually do is I take the tip of the snare and use soft coagulation, and then just push with the tip of the snare against the vessel and just hit the vessel with some coagulation current. Usually it stops. That's the easiest way to perform, to stop the bleeding. I think in 90% it's done with that. I very rarely use a coag-grasper or a clip at the end, but that's usually not necessary. That's usually the snare tip coagulation is the most effective and quickest way to stop the bleeding.
One technical point there is if you're using the smaller of the Cook band, it only takes a 7 French device, and so you really are limited to the snare that you have. You can't get a coag-grasper, so you're kind of limited to snare tip soft coagulation. But I'll use that a lot before I take the device off and go to a coag-grasper or some other tool.
I mean, the bleeding rates are really very low. I think I just wanted to comment on one thing. I follow what Mike and Arjun do in terms of working from the oral margin to the anal margin. I suppose the only exception is if I know I'm going to do a large piecemeal resection and there is a particularly high risk area in the center of this lesion. I normally will start there and take that off in one and then fetch that specimen and put it in a separate pot and say to Marnix, you know, Marnix, have a look at this one before you go anywhere else, and then, you know, work around that and then follow. So I suppose that's just maybe a little tip or trick if you're going to do a big resection. Just go for the you know, what's going to give you the most information in terms of prognosticating this patient's path is, you know, because the last thing you want to do is do 10 resections and then it'll be the one lesion that you don't find in the hiatus hernia. So that's just a little tip that sometimes I do. Yeah.
It's a really great tip. Marnix, I think on the piecemeal resection subject that Rayhan's alluded to there, you know, very briefly, we'll just talk about, we talked all about deep margins, you know, just a minute ago. Circumferential margins in piecemeal EMR, do they matter? Sometimes our pathologists say to us, oh, by the way, there's low grade in your, or high grade in your circumferential margin or whatever else. You know, tell us, should I worry about that?
Well, I think this is a recurring theme, right? We've said already data light, Ray, and as you said it, of course, in most cases, piecemeal resections, we can't say anything about it, and I will not mention this in the bottom line of my report to make sure that there's no confusion over this. I might describe when there is cancer in a lateral margin to let you know this, but essentially, I trust that's in most cases when there is high grade that you've effectively treated that as well, and I won't make specific mention of that.
Well, Marnix, can I just ask you a question here? And it'll be interesting to see what the other centres do. In that we've had this ongoing debate about what qualifies as a deep vertical R0 resection in endoresection specimens compared to esophagectomy specimens, and what is the minimum depth clear of the margin that from the deepest neoplasia that will lead you to press a 0 rather than a 1 on your report. Just tell us what is that in terms of endoscopic resection specimens compared to esophagectomy specimens? Because I get a lot of colleagues calling in from other centres asking, my pathologist has said this is an R1, but actually it's only 500 microns, or what is the cutoff internationally?
So this is, by the books, this is the rule. For an esophagectomy specimen, you want at least 1 millimeter to the margin clear. If it's within a millimeter, it's an R1 surgical excision. For an esophagectomy, for an EMR or an ESD, what we generally keep to is that it's really tumor touching the ink of the specimen. However, this is where the interesting bit comes in. I've been working on a study together with Arjun as well, whereby we've retroactively pulled a lot of these cases that were called initially as R1s and then reviewed them within a group of expert pathologists, firstly to see can we have some sense of concordance on this. And actually you find that for some of these cases, is if you review them, that a lot of times an R1 excision will also be due to technical factors whereby there might be a bit of twisting, a bit of torque on the side of the specimen, right, which is then overcalled. So I think that you rightly made that point, Ray, and to first take out your most disconcerting part of the lesion, put that in a separate pot. All of that will aid proper workup and will make sure that you avoid an artificial R1 margin, really.
So 500 microns? You didn't answer the question.
No, I did answer the question, I think. So for me, any margin, be it 2 microns between the tumor and the deep margin, is enough to call it an R0 excision. Also because I trust your endoscopic eye to be confident that you've taken out the lesion, really.
Brilliant, thank you, Marnix. And look, we're going to talk about this a bit more as we go on to the MDT and later on, so that will come back up. But let's move on to our next case. So this is Rayhan's going to talk us through this case, but this is a 64-year-old gentleman who's referred to us for assessment of high-grade squamous dysplasia, with the plan to obviously resect that by ESD. And actually in this case, Rayhan elected to put a prophylactic stent in for stricture management, which I'm sure he'll talk about during the case. So this uses a Pentax I10 gastroscope, the Olympus Dual J and IT2 ESD knives, and then the stent is a Boston Wallflex stent. So let's play the video, and Rayhan, over to you and Mike to talk through the case.
Okay, thanks, Dave. I'll talk this over with Professor Wallace. So this is a patient. If we can just see the video, please, on the studio screen. So we seem to be getting a few more of these referrals just over the past few years, David, which clearly means that your imaging courses are working and people are picking up these subtle lesions. So we'll just wait a few moments. So here is the first part of the procedure, Mike, as we said, is really establishing the distal and the oral and the anal margins of the lesion, and often this can be quite difficult to do, and I think this is really important so you don't undertreat the patient. Unlike Barrett's, this is really important because you don't want to leave any dysplasia behind. So in this patient there is this sort of mosaic pattern of dysplasia, and so it often can be very difficult to do a sort of hemicircumferential or a three-quarter resection. So in these patients, and actually from my teaching from the two faculty members, has been to really do a circumferential resection. It's a lot easier, and that is essentially creating either 2 or 3 tunnels. In this case, Mike, what I've done is I've marked the oral lesion and the distal lesion. The one thing that wasn't mentioned here, Dave, is this chap had previous radiotherapy for a squamous cancer. So this was either a recurrence or a metaculous lesion.
And that makes it harder.
It does make it harder in terms of the tissue plane. So what I've done here first, Mike, I don't know what your approach is. I've done a circumferential mucosotomy at the anal end. And then I use a combination of, this is the Olympus dual knife, just to make a small mucosotomy, and then I just feel more comfortable with the insulated tip knife in these patients where they've previously had therapy where the submucosal plane may not be as robust. What's your reflection on this? Did you do anything differently? Would you use a slightly different knife for this?
Yeah, so first of all, the technique here of doing essentially an en-bloc, completely tubular 360-degree resection, I've used the exact same technique in this setting where, in the end of the day, if you've got multifocal lesions and you're getting close to 360 degrees, it's actually technically easier, I think, to do a 360-degree than to do, say, a 270-degree resection. And I do a 2-tunnel or 3-tunnel. I typically will do the string clip traction methods. So once I get the first tunnel done, I'll put a little clip attached to a string to hold the tissue because it gets very bulky and bunched up and hard to do the second tunnel. The other little trick I've learned is make sure you get your distal cut deep enough.
So true.
I've made the mistake of going under the cut, not realizing that I've already reached it. So make sure you get down to the muscle layer with that distal cut first.
And that's, you can see here that the first tunnel, we're just coming to the end of that. It's such an important a tip that if you invest in that first mucosotomy, you will avoid a situation where you will not come out of the tunnel and you will carry on. And I've done that before. So you can see here, this is the first of tunnel that's been created. There's a little bit of muscle exposure on the proximal end due to perhaps a slightly deeper mucosotomy, so it's really important to look at that early on, just make sure that you don't need to put a prophylactic clip on. And then actually on the posterior wall, you can see the submucosal plane is so much more evident compared to the anterior side. So here you can see the tunnel is almost completed, and you've completed the 2 tunnels, and as Mike said, the distal margin is really clear. So you get a little bit of instant bleeding here. So Mike, what I've got here is I've created my 2 tunnels, and then the question is really, what do you do next? So I've kept these 2 tissue bridges on the proximal margin. This is something that Arjun taught me. And then what I'm going to do is I'm just going to release one of these, and then use either a combination of gravity, which actually can be really, really helpful here, which will act as a sort of pseudo traction method to release that first submucosal bridge. But as you said, the posterior bridge is then, this is where you need your traction. In this case, actually, I can't remember exactly. I think just the weight of the specimen going south was enough to give me enough of a sort of physical margin to be able to cut this. And then here I've used a combination of the dual knife and then the hybrid knife, and you can see that reasonably quickly, within a couple of hours, you can get a circumferential resection. Any observations on that? So there's the lesion, Mike.
Yeah, there's. I think we all have slightly different techniques. I do the same top and bottom tunnel. I have found I use a technique that Ken Wang and Prasad Iyer describe, which is then go to the scissor knife.
Yeah,
one of the SB knives or the clutch cutter. You have the traction of the 2 lateral edges that are still under tension, and you can very quickly scissor your way down that. But really we all have. That's obviously just an issue of personal preference, but.
So Mike, this is where this is open for discussion. I am really struggling with these strictures because I'm making a lot of asymptomatic patients symptomatic. So I then started putting stents in, and then I opt to here I've used the OTC clip. Sometimes I suture them in. I've tried topical steroids. I've tried post resection triamcinolone injection. I have tried prophylactic dilation and perforated someone 2 weeks later. I just don't know. Help.
Yeah. You know, the data on the oral viscous budesonide, we heard a little bit before. We did a case control trial with Michael Bartel and Heiko Pohl a couple years ago now, and you know, at least in a case control trial, seems to be helpful. In the end of the day, I have not routinely stented these. I tend to bring them back early for dilation, and then do 2 or 3 serial dilations, and that usually gets them back open. I've not had a case where I couldn't get them back open.
Yeah, no, sure. But it's a consideration, actually. When you know, maybe Arjun, Ollie, your thoughts on this, and then we'll come to Marnix. Is when I do these cases, my surgeons say to me, well, actually, when we do an esophagectomy, we put a feeding jejj in. So I know that Raf Bishops in Leuven will often put a prophylactic gastrostomy tube in these patients because of the impact on their nutrition. So Arjun, your randomized trial will hopefully inform my uncertainties, but what are your reflections? What do you guys do?
So I think there's no evidence that this stent will help, or at least not that I know of. Placing a gastric tube, well, it will maintain some kind of luminal patency, at least so you'll be able to pass it and dilate, but I don't think it will do anything on the stricture development or the course of it. So far I've seen cases, of course we have to await the results of the trial, but in some patients there's actually, when we go back 8 weeks after, there's no stricture at all.
Wow.
Which is so surprising to me because of circumferential resection. I would expect 100% certainty of having a stricture. So I hope this was because of the budesonide, because it was double blind, of course. We have to see about that. But so I think that's the way to go. And but trials on stenting, prophylactic stenting, well, should be good if we do that in some kind of a randomized trial.
Oh, fantastic. Ollie, can I ask you a technical question? Both Mike and Rehan here talked about traction and traction techniques. What are they?
So usually it's the clip and string technique you can use here. So you use a clip that you can open and close, and then have a thread outside the scope and grab the tip of the thread, or tie the thread to the clip, but the thread has to be outside the scope, and then you clip it to the margin, the proximal margin of your resection specimen, and then you can apply some traction. And this really helps a lot, especially for those circumferential ESDs, or when you have a larger, more than a semi-circumference, then I usually use it. You can also use a soft snare, so like the snare you use for the multiband ligation, and then you can clip this towards. Then you can also push a little bit, so you have you can push and pull. This is also sometimes helpful for ESD.
Marnix, can I just ask you a question about the pathology in question here? You know, Professor Wallace alluded to how Barrett's and squamous neoplasia are 2 different beasts, and so, you know, what are the considerations from a histopathological point of view in you know, the assessment of a squamous resection specimen? You know, you've published on glands before and their presence or absence in terms of prognosticating just how deep we've gone, and you know what the risk of subsequent recurrences, because this is a cohort of patients who we do not want to undertreat. So, you know, your considerations as a pathologist of what we're sending you.
Yeah, absolutely, Ren. So there is a clear difference in biology of these 2 beasts, right? So we know that Professor Wallace already said that these squamous lesions are, of course, much more worrisome, even with superficial infiltration depths. And we send patients for surgery earlier on because of their risk of local regional mets. And on top of that, there's also the issue that you just mentioned, that very often these squamous lesions infiltrate in the submucosal gland ducts, which might mean that if you're working with a specimen that is particularly distal, where there's lots of these submucosal gland complexes there, that often those lesions extensively work their way down into the submucosa. They might not infiltrate there, but it means that if you have a relatively superficial ESD, you're still leaving behind remnants of that lesion there, which then of course can be buried, is the proper term here in this context, really, for later recurrences. And it's difficult to really reconstruct whether that was the case, but there are some examples in trials where this has been seen, I think, and that's a really difficult assessment to make, I think, during excision. I've often understood that you can also visualize these as tiny grains of rice there in the submucosal layer, so to pay attention to those. And for the pathologists as well, it's also, you have to be keenly aware of the biology of those lesions. Yes.
Thank you. Thanks so much for that, Marnix. And we're going to go straight on to you. So you yourself and Arjan sort of recorded an NDT essentially for us to watch on some of these trickier cases. So let's watch that video. We've got time for discussion after that. So let's see their video.
Good afternoon. Thank you very much for the kind invitation to discuss the issue of T1B disease during this session of the Oesophageal Neoplasia Masterclass. My name is Marnix Jansen. I am a consultant histopathologist in the pathology department of University College Hospital here in London. And my co-presenter is Dr. Koch from the Erasmus Center in Rotterdam. Arjan, you might want to introduce yourself.
Yes, thank you, Marnix. Yes, my name is Arjan Koch. I'm an interventional endoscopist at the Erasmus Medical Center in Rotterdam, the Netherlands, with a special interest in Barrett's neoplasia and endoscopic treatment.
Excellent. And the two of us will, in the next 10 or 15 minutes or so, highlight some current issues with the management of these patients with complex T1B disease, and in particular, address the topical question of when it's still safe to continue endoscopic management. And to do this, we will first discuss two exemplar clinical cases with you. And on the back of that, we'll discuss some recent studies that have come out on this work, and also current work that we're doing to further risk stratify such patients within a real-world setting in the context of the PREFER study. And this will be followed by an NDT discussion with some of the faculty that you've already seen this morning during ONM. Right, we'll kick off with the first case. Dr. Koch.
Yes, well, this is a case not done by myself, but my colleague, Rayan Hadri. This is a 78-year-old male with a history of COPD. Here you can see his Barrett's esophagus, prior classification C2M5. And as you can see, there is a nodular area in the Barrett's, and this patient was referred for endoscopic resection. Here you can nicely see with the iScan 3 the vascular distortions in these nodular areas. And if we wait a moment, there's another close-up here where you can see the nice vascular distorted patterns. And I think this is a clear indication for endoscopic resection. Now, in a few moments, you will see that Rayan chose to remove this lesion with a piecemeal EMR, a multi-band mucosectomy, I presume. And here you can nicely see that the whole lesion has been resected. Of course, this was sent for histopathology, and I think Marnix will show us the slides. Marnix.
Exactly. You can see the overview of one of the EMR specimens in that patient here, and it's clear that, just to orient yourself, here these bits here and here are overlying squamous epithelium. So this is at one of the squamo columnar borders. We have some submucosal gland complexes here, and really right in the center of the specimen, here is that lesion. where we can go to just a bit higher power, where again, you'll appreciate here the squamous lining, normal Barrett's mucosa here, and these glands which are haphazardly infiltrating the underlying tissues. And if we're at highest power, here you'll find the muscularis mucosae, which is slightly distorted and also frayed because of the effects of this lesion that infiltrates here. And if you continue this line here, which is what we generally do when this anatomical landmark has been destroyed, you'll see that this lesion just about infiltrates the upper layers of the submucosa. So a very superficial T1b SM1 lesion. Well, this of course might be considered a straightforward case. We know, however, that even such cases can generate some discussion amongst pathologists, and there is inter-observer variation in that regard, i.e. the deepest point of invasion, so whether a lesion is actively classified as an SM1 or an SM2 can be subjective to some point. As I said, an issue there is that these anatomic landmarks, the muscularis mucosae, is often destroyed by the early invasive lesion. And another issue might be that in some cases, here this was clearly a moderately differentiated lesion whereby all of the glandular contours were clearly outlined. In some cases, it might be difficult to consider whether a lesion also is poorly differentiated. Now, we know that in such patients, of course, deeper invasion and also the additional poor prognostic risk markers such as poor differentiation, which I've already mentioned, and lymphovascular invasion affect their outcome. And the absence of such poor prognostic markers, patients even with T1b disease will often have an excellent long-term outcome. And in such cases, we must weigh the risk of esophagectomy with the 30-day in-hospital mortality risk of still 2.5% or around that mark, 2 to 3%, to be weighed against the survival benefit for these patients, especially within this sometimes aging patient population. So this is just to set the scene. We can now discuss the following patient. Dr. Koch, I hand back to you.
All right, this is the second case, a 48-year-old male with a Barrett's C1M3 under surveillance and no visible lesion at that time. He is a fireman, has no comorbidities, otherwise healthy, and he underwent multiple endoscopies for GERD and was diagnosed with a non-dysplastic Barrett's. So he was, I think, on his own choice, referred to another center, and he had an endoscopy in 2017 where a Paris 2A plus 2C lesion was seen with ulceration and lack of acetowhitening. I think you can see the corresponding picture here. Not very clear, but still. I'm not sure what, not consented for resection.
Yeah, so this patient was initially, that was an unexpected finding during the endoscopy, and he wasn't consented for resection ahead of endoscopy. So at that stage, only the biopsies were taken.
Right.
And I can show you those here. So these are the histopathology of those biopsies, which reveal some of those issues that we discussed earlier, is that this case shows in the center of your view, shows a single gland, which might be a remnant gland of the pre-existing dysplastic lesion, but that gland is actually surrounded, enveloped by this plaque of poorly differentiated tumor cells. So this was returned to the referring endoscopist to say that the biopsies of that 2A, 2C lesion at the GOJ had poor histology, and then discussed for MDT.
So he had a full staging and was discussed. Staging showed no signs of a lymph node metastasis or distant metastasis, and it was discussed, and it was decided to go for endoscopic therapy. So this lesion was removed again by piecemeal EMR, 6 pieces. And as previously mentioned, it was a 2A plus 2C lesion encompassing 75% of the circumference of the esophagus.
Yes, and I'll show you the histology here. So again, just to orient yourself, here on the side we have squamous epithelial lining. Here with just a few glands likely of the pre-existent Barrett's mucosa there. Here, these are submucosal mucus glands. And then here is the muscularis mucosae. So quite deep to the actual lesion. Here, where we've just a second ago seen the biopsies, we can go one step to higher power and we'll appreciate that the lesion is only limited here to the upper reaches of the tissue. And if we go to highest power, recapitulate that point that this is a poorly differentiated lesion. Here there are some remnant glands for comparison, but these are just one expansive lesion of poorly differentiated, poorly cohesive tumor cells, some also with signet ring cell morphology, and just below that here are the first muscle strands of a duplicated muscularis mucosae. But in effect, this is a lesion which is completely situated within the mucosal layer, and for that reason, a T1A, poorly differentiated lesion, no evidence of lymphovascular invasion. Arjun, back to you.
So a poorly differentiated lesion with signet ring cells on histology. It was decided on endoscopic follow-up. Patient had a dilation performed for a stricture developed after this large EMR. Balloon dilation up to 18 millimeters. Endoscopy showed no residual Barrett's, but still he had a radiofrequency ablation of the G junction. And as we said, he had several surveillance endoscopies from June to 18 to June 1920.
Yes, and all of those were negative?
They were all negative. He was a healthy fireman. He completed the marathon in April 21, but only a month later he was admitted to a local hospital, and staging then revealed, unfortunately, that he had metastasis in his lungs, in his bones, and also lymph node metastasis at that time of unknown primary. He had bone marrow failure. Again, a gastroscopy at that time showed no recurrence of his original disease. But biopsy of the lungs and lymph nodes confirmed adenocarcinoma of the upper GI tract that was compatible with the original tumor that was removed in his Barrett's esophagus. And the patient died in June 21.
Yeah. So in many ways, a dramatic disease course, of course, for this patient. And we locally reviewed the pathology and compared that with the original lesion. So of the metastasis, and that showed a comparable histology. So very likely that this widely metastatic disease, which developed 4 years after the initial resection, did derive from that lesion that I showed you previously. Of course, important to note that this was a patient which would be considered at the moment to have a low risk of later progressive disease or local regional metastasis, because his disease was contained entirely within the mucosa, T1A, no lymphovascular invasion. And actually, what I showed you was the only focus contained within a single EMR, so a really small volume of disease as well. And for us, this was a very instructive case because we've had discussions after this with regards whether we should have acted earlier, of course, whether a patient would have benefited from surgery at an earlier stage, or maybe systemic treatment. One point of view might be that with such aggressive disease, there is a possibility that that disease was already metastatic at the initial stage of endoscopic treatment, and that surgical management at that stage would not have made a difference. But by the same token, we would have had no arguments other than his mucosal poorly differentiated disease to start systemic therapy either. And I think handing back to you, Arjun, that this really illustrates the dilemma with these patients still.
Yes. I think this case is always still a good discussion for the MDT discussion later. But to come back on T1B disease, I think a lot of problems there. All guidelines that I know of, at least, recommend surgery in these cases. And that is because the risk of lymph node metastasis is considered to be higher than the risk of mortality associated with surgery. And so that accounts for all cancers, SM1 or any T1B with one or more high-risk features. Usually we don't make any subdivision for individual risks of lymph node metastasis. And how can we assess mortality risks for an individual patient? And not only mortality, but also morbidity, which can be considerable. So why do we operate all when only the majority, when the majority will never develop lymph node metastasis? I think there is a fear of undertreatment, and somehow it seems to be easier to accept overtreatment. But the question is, can we define subgroups that are less likely to develop lymph node metastasis or vice versa? And is watchful waiting a feasible option in these patients? And can we predict surgery-associated morbidity and mortality on an individual basis? So I think up till now, there's no holy grail. It's quite a dichotomous approach to decide on patient management. It's T1A versus T1B, or SM1 versus SM2 or 3. Low risk versus high risk is what we find mostly in the literature. I think it's time, at least, we should try to have a more personalized approach. A more individualized lymph node risk prediction based on a combination of all the risk factors that we know. And then the question is watchful waiting after a radical endoscopic resection and no lymph node metastasis on imaging a feasible approach? Next slide, please.
Yes.
So one of the studies that we recently published is the Sublime study. These are all cases in the Netherlands for a T1B esophageal adenocarcinoma. We were able to find over 500 cases in our National Cancer Registry, and we had the primary endpoint was the presence of lymph node metastasis in the surgical specimen, where at least more than 12 or more lymph nodes had to be resected, or development of metastasis during follow-up, and that was at least 5 years. We performed a statistical prediction model, and unfortunately we didn't have enough cases to perform external validation as well, so this is an internal validated model only. It has a good C-statistic of 0.81. And finally, after excluding cases that we couldn't include, we had around 250 patients left. And in this group, we found in 78 of these cases, lymph node or distant metastasis during surgery or during follow-up, and 170 cases remained without any metastasis. So in the next slide, you can see this cumulative incidence of metastatic disease over a course of around 7 years. You see that most lymph node metastases develop in the first year. It's also because of surgery, of course, but in the years after, not a lot happens. Based on this, we try to develop our score chart for a 5-year metastasis risk. And if you look at this score chart, you can see that we looked at SM invasion depth, lymphovascular invasion, yes or no, and tumor size. And if you look at the upper left, you see that an SM1 lesion without lymphovascular invasion and not too big has a relatively low chance of developing lymph node metastasis in a 5-year time. Compared to on the right lower side, you have the deep SM submucosal lesions with lymphovascular invasion in larger tumors that have a really high risk of lymph node metastasis. So based on all the histopathological parameters, you can use this to discuss with the patient their individual risk and not just put every T1B in one big pile. This is good for discussion in your outpatient clinic. Of course, the proof of the pudding is watchful waiting a feasible strategy. We have to know how good is our safety net. If we do perform endoscopic follow-up with endoscopy and endosonography, can we detect lymph node metastasis in an early course where there still can be a curative treatment? And somehow, Marnix, we have the same problem. We don't see the text here.
I don't see the text either, but I think we can discuss this.
So the preferred trial is exactly the clinical trial that is going on now since 2017. It's a multi-center, multinational trial where patients are included with a T1B esophageal adenocarcinoma or a high-risk T1A. And they have endoscopic follow-up for a course of 5 years. Very intensively, the first 2 years every 3 months, then 6 months the next 2 years, and after 5 years, a final follow-up. And they have a PET-CT scan after 1 year. We're still in the middle of the trial, of course, so we cannot show you the final data. But I think this is something that we can maybe now discuss in our
yes, exactly. It's a study spearheaded by Dr. Roos Pauw from the Amsterdam Medical Center, and despite the fact that the text is not showing here, I'm confident that this will come up in the MDT discussion that we'll now have with the rest of the faculty, and we'll show you that slide then such that you have all the details there. Thank you very much, and I will now hand back to Vinay and Rehan for further discussion. Thank you.
Thank you.
Marnix, Arjun, thank you very much. That was fascinating, and really it puts a sort of clinical context of we talk about endoscopy videos and slides, but that puts the whole sort of context of the clinical journey of these patients from start to finish, which is often really important because you talked about some comorbid patients there, you talked about young people, and we need to take all of these things into consideration when we're counselling our patients as to what is in their best interest. But Marnix, let me just pick your brain about Prefer. We're also lucky to be contributing to this, and Mike and I were talking about it earlier, and Dave, it's a pretty data light field. So the interim analysis, and we'll see the output at DDW in a few months. What's your take on how this is going to play out? Because Arjun mentioned the sort of watchful waiting approach for those at sort of moderate risk. You think that our oncologists and our surgeons will be? We're obviously we live and breathe this every day, but how are we going to play that out with our oncologists and surgeons? Do you think that'll sit well with them?
Well, I think, Brian, this is the best evidence that we can present them, right? This is not a field for doing a proper randomized controlled trials whereby we submit patients to surgery to see what their long-term outcome is. So this is really the highest grade evidence that we can present there. The data, the interim analysis does indeed suggest that this is safe for those patients, and especially in that comorbid elderly population to discuss with them. I think one of the unspoken truths is also that what Arjun and I just showed, most of these histopathological criteria are still subjective and qualitative. And what we need are true markers of biology of disease that will show us in these patients which patients are still at high risk. And in other contexts, early colon cancers, of course, we're now looking at circulating biomarkers. That, I think, will be really the next step after this, future, maybe 5-10 years from now, when we have really sensitive markers to still pick up the few patients that you want to approach aggressively early on.
Yeah, thanks, Marnix. Ollie, let me ask you, as the faculty member who's actually published on the largest cohort of patients in this in this field, albeit a retrospective series from your days at Wiesbaden. What are your thoughts on, what's your practice in Germany, and do you think there is a wind of change now that we're going to be able to treat more aggressive, deeper disease and be able to confidently tell our MDT that these patients will be surveyed long term in an accurate manner, so to speak?
Yeah, we also do the same. So we are including into the preferred study also since a few years, and I think this is really helpful to do this, because then you can include all those patients with those high-risk SM cancers or those high-risk T1A cancers into a study with a close follow-up. We did this already before when we collected our data on the SM patients. So we did very close follow-up with EUS endoscopy and CT. So it was a very similar protocol, but now we can do it in a multi-center study and then collect the data for this. And my daily experience is patients don't want to have an oesophagectomy when you can offer them really a good follow-up. And the question always is, do you miss something when you find a lymph node, for example, half a year later after your endoscopic resection, and then do a proper neoadjuvant therapy like a chemoradiation, and then do operation? Because that's, I think, the most important point. We know from those oncological studies that a neoadjuvant treatment for N1 positive for N positive patients really have a significant impact on their survival. And if you would treat those patients who have a lymph node metastasis, but you don't detect it at the initial staging, and would send them to surgery after you detected SM2, for example, then you don't have this neoadjuvant treatment for those patients. And then you really lower their survival rate. And I think this is a very good argument for them. And what I usually do is, when you tell them, okay, you have an SM2 tumor, you have an increased rate for lymph node metastasis, so it's about 10% or something like that. And then you can tell them also, so in 90% of the cases, the surgery would be without any impact. So you would have a surgery, but you don't have a profit of that. Only in 10% you might profit from the surgical intervention. I think you have to turn it also around. Not only say you have a 10% chance, but you have also 90% chance to be cured by endoscopic treatment.
And that's what patients want to hear. I really like the way you've articulated that. Listen, we could carry on talking about this all morning, but a huge thanks to the three of you, Ollie, Marnix, Arjun. Really good to see you, albeit across a TV screen. Really fascinating stuff, and thanks for your time. And lots to reflect on. So I'm going to hand over to Dave to take us into the next session. But thanks, guys, and we'll see you soon.
Yeah, thank you so much, Rand. So we've got a 5-minute break to give everyone a little bit of a chance to get some refreshment. So don't go too far, but we'll see you in 5 minutes to start the next section, which is on ablation in esophageal neoplasia. So see you in 5.
Welcome back, ladies and gentlemen. I hope you've suitably refreshed yourselves after what was a very busy but also very interesting morning session of events. I think I'd like to take this opportunity to invite a very good friend of mine and colleague, Professor Bas Voisten from Utrecht. Hi, Bas.
Hello, Vinay.
Hey, great to have
Nice
you, Bas. Good to see you again.
Thank you.
It's
great to be here.
It's a real honor to have you join us today. So, ladies and gentlemen, the focus of this session before lunch today is really focusing on ablation. So we spent a lot of time discussing staging and sampling and tissue resection methods in Barrett's, but we know that that's not the end of the story, and we know that we have to go on and ablate, particularly in Barrett's, the residual Barrett's segment. And we'll discuss a lot about RFA, but I want to focus actually at the start of this session with a new kid on the block. And can we actually replace heat-based therapy with freezing and cryotherapy? And there's no one better versed and knowledgeable than Professor Voisten at this. And Bas, I think what we're going to do to start off with is really go into your lecture, which is a great overview of the evidence to date and the pathophysiology and mechanisms of action of cryotherapy in esophageal neoplasia, and then we'll come back and have a Q&A with Lawrence Lovett and Rayhan Adrian and yourself. That's okay. So if we can go through to the recorded lecture, please.
Dear ladies and gentlemen, let me first thank the organizers for inviting me to deliver this lecture on cryoablation with the title Cryoablation Has Cold Replaced Hot in Ablation of Barrett's and Esophageal Squamous Cell Neoplasia. My name is Bas Voisten. I'm a gastroenterologist in the Netherlands, Utrecht University Medical Center and in the St. Antonius Hospital in Nieuwegein. These are my conflicts of interest. Let me start with asking the question, do we need a competitor of RFA or APC in ablation of esophageal neoplasia? And to answer that question, you can also ask, what are the potential benefits or advantages of cryoablation over heat-based technologies? Well, the first is that cold, in contrast to heat, preserves the extracellular matrix. The extracellular matrix consists of protein molecules, and those are denaturated when exposed to heat, such as RFA or APC. And the preservation of the extracellular matrix by cryotherapy might allow for deeper ablation without causing perforations, and that might be an indication, therefore. A second potential advantage is that cold or cryotherapy is associated with less pain compared to heat. That's well known from other fields of medicine. It's well known even from randomized clinical trials on, for instance, cardiac ablation for atrial fibrillation, but also from solid tumor ablations. And there's also a pathophysiological mechanism behind that. Cold decreases nerve conduction of nerves involved in pain perception, and also reduces the release of pain-associated or inducing cytokines. There are basically two systems. A true freeze system, which is currently only available in the United States, as far as I know. It's a spray catheter with liquid nitrogen. And there's the C2 cryoballoon ablation system, which is available in the UK and in other European countries. And let me first explain to you the cryoballoon ablation system for those who are not familiar with this system. It consists of a handheld controller, a foot pedal, and a balloon. And this is when all things are mounted together. This is the handheld controller, and below this cap or underneath this cap there's a cylinder containing nitrous oxide. The balloon is attached to the handheld controller, and there's a foot switch also attached to the same controller. And let's zoom in on the balloon. This is a schematical representation of the balloon with an inner catheter with 2 shafts in it. Liquid nitrous oxide exits the cylinder and runs through the catheter, and when it exits the side hole, it transforms into gas, and that is associated with a decrease in temperature to -85 degrees of Celsius. And this expanded gas is then vented back through the separate side hole back towards the handle. And that prevents overinflation of the stomach, for instance, which is a problem when using cryospray technology. This is how it looks like in real life. You look through the balloon now, you see the diffuser or dispenser of the cryogenic fluid. You can also see that you can maneuver the catheter within the balloon in axial direction, and you can line it up with the spot of Barrett's you wish to ablate, but you can also rotate the diffuser within the balloon while the balloon stays inflated, and you can aim for the Barrett's Islands here at 9 o'clock and then ablate that as well. And those movements of the inner catheter within the balloon is controlled by the foot switch, which can, when activated, move the inner catheter in axial direction as well as rotationally. And here you can appreciate the ice patch, which is a result of the freezing of the cryogenic fluid. There is a second type of balloon which is designed for ablating larger areas, and it is known as the 180 catheter, and the principle is the same, but it's slightly different. So again, the liquid nitrous oxide exits from this canister through the catheter and exits now not through a circular side hole, but a more fin-like exit port, and then there's a spray of such a shape, and then the inner diffuser automatically retracts and freezes the esophagus for half of the circumference at the temperature of -85 degrees of Celsius. And again, the expanded gas is vented back through the separate channel in the catheter backwards towards the controller. This is an example of the 180 in action. You see that the diffuser is distally located in the balloon, and when you activate the system, it automatically retracts at a predetermined speed, and you can imagine that the speed of traveling of the diffuser within the balloon is related to the dose intensity or the depth of ablation. And you can see that there is an almost or slightly more than half of the circumference ablation. And then, of course, you can rotate the diffuser again while keeping the balloon inflated, and then ablate the opposite side of the Barrett's esophagus. Using the focal balloon, you can do a circumferential ablation in a similar fashion as you would do with the RFA. So using side-by-side ablations, which is displayed in this short video, you can end up with a circumferential ablation of the esophagogastric junction in this case, or other areas in the esophagus. So this is the second ablation. Then you can do a third ablation with a minimum overlap. Some overlap is not a problem. And then you will end up with a circumferential ablation. And then if you wait a minute or a couple of minutes, and if you wait until the ice patch is gone, you can see that the ablated mucosa turns purplish are beefy red, as they call it, and that is a sign that this area has been ablated. So what is known of the efficacy of cryoballoon ablation for Barrett's esophagus? Well, the largest study so far is published by Mimi Kanto 2 to 3 years ago, and she reported on 120 patients with a Barrett's esophagus with a median length of C 1.2 centimeters and M 3.2 centimeters, and a maximum length of 6 centimeters, with almost in half of the patients preceding endoscopic resection. And by side-to-side ablations, they ablated all visible Barrett's with a maximum of 5 treatment sessions. And the technical success was 95.8%. And in the per protocol analysis of 94 evaluable patients, after 1 year, there was a complete eradication of dysplasia in 97% and a complete eradication of intestinal metaplasia in 91%. So that's quite impressive, with a 12.5% stricture rate. And here you see in blue the complete eradication of dysplasia, and in yellow the complete eradication of intestinal metaplasia. And in the left, it is, sorry, I mixed it up. This is complete eradication of dysplasia in an per protocol analysis, and this is the complete eradication of dysplasia in an intention to treat analysis. And likewise, this is the percentage of complete eradication of intestinal metaplasia in a per protocol analysis. And here you see the same in the intention to treat analysis. There are very few direct comparisons. This is a matched control study in 20 patients undergoing focal cryoballoon ablation and 26 matched controls treated by RFA, a single ablation treatment, so one endoscopy, all flat type Barrett's using side-by-side ablations. And so 20 cryoballoon, 26 RFA, and here the outcome was the percentage of Barrett surface regression after a single treatment session. And you can see that there was not a significantly different difference between cryoballoon ablation and RFA, with a high percentage of Barrett's surface regression after a single treatment session with the focal device. However, there was a significant difference in pain, both the peak pain and also in terms of duration of pain and the use of analgesics after cryotherapy as compared to RFA. And that is displayed in this graph. Here you see at the y-axis the pain score from 0 to 10, and this is a 14 days or 2 weeks time period. And in blue, the pain scores after cryoballoon, and in red, the pain scores after RFA, and you can see a significant difference. Also, the duration of pain was significantly shorter after cryoballoon compared to RFA, and also the use of painkillers was significantly less in the cryoballoon ablation group. Another potential indication for cryoablation is the so-called refractory Barrett's cases, and this is a study from UCLH in 2020, and they reported on 18 patients with a median Barrett length of 3 centimeters with low-grade dysplasia, high grade of intramucosal cancer. And those were refractory patients, and that was defined as either a failure of 3 ablative procedures with RFA or APC, or less than 50% Barrett surface regression after 2 ablations. And they reported on the outcome after a single session of cryoballoon ablation using the focal catheter and side-by-side ablations. And there was a complete eradication of dysplasia in 78% and a complete eradication of intestinal metaplasia of 39%. So that is, I think, quite a good result. But of course, this should be studied in further detail. There were also reports on cryo as a rescue. And this is a case we recently reported of a patient with a poorly differentiated esophageal adenocarcinoma who refused surgery. And he was treated by chemoradiotherapy, and he developed a recurrence, and we performed an endoscopic resection. At least we tried to perform an endoscopic resection, and that came back as a T1B SM3 poorly differentiated cancer with a clearly positive deep resection margin. So we again urged this patient to go and see the surgeon, but he again refused, and he said, well, I want to be treated with something different, less invasive, and we offered him a rescue cryoablation therapy. So we treated this area with 3 double ablations of 12 seconds. And that is quite a high dose because the regular dose for Barrett's ablation is 8 seconds. And you can see here the ablation effect, and this is in short-term follow-up, and after a long-term follow-up there was no recurrence of cancer. Of course, this is not a proof that it's effective, but it's a suggestion in a single case. So let's now move on to esophageal squamous cell neoplasia. The first report on cryoballoon ablation in squamous epithelium is again reported by Mimi Kanto a couple of years ago, and she reported on a multicenter experience in 10 patients with low-grade intraepithelial neoplasia, hygiene, and esophageal squamous cell cancer. And there was a complete eradication of the lesion at 3 months in all patients, with a stricture requiring dilation in 2 patients. Esophageal squamous cell neoplasia is relatively rare here in the West, but it's a very frequent disorder in the East, especially in high-risk areas in China, where well, overall, 90% of all cases of esophageal cancer worldwide is esophageal squamous cell cancer, and most are diagnosed outside the Western world. So what we did a couple of years ago, we performed a study in China, and in China we treated 80 patients with an lugal voiding area or an unstained lesion, a USL, of less than 6 centimeters and less than 50% of the circumference, containing either MGIN or hygiene. And repeated treatments were allowed, and the outcome was complete eradication of neoplasia at 12 months. So at baseline, we were able to treat 79. One patient, there was a laceration, and the patient withdrew the informed consent for further treatment. And at 3-month follow-up, 70 out of 79 patients were in complete eradication. 1 was lost to follow-up, and in 8 there was a persisting unstained lesion on Lugol, and those patients were treated with a second cryoballoon ablation. After 6 months, those 8 were free of dysplasia, and at a 12-month follow-up, there were 2 out of those initially 70 patients who were at complete eradication after 1 ablation, who showed to have MGIN, so still dysplasia, but overall 76 out of 79, or out of 80, being 95%, were in complete remission of dysplasia. So that is quite impressive and also encouraging. However, we have learned from previous studies in squamous neoplasia with RFA. This is an image of from that article reporting on this study. Because we also performed a couple of years earlier a similar study using RFA in squamous. That treatment cohort consisted of almost 100 patients, also with a flat unstaining lesion, so lugal voiding area, with either MGN, hygiene, or esophageal squamous cell cancer. And circumferential RFA and focal RFA was performed, and the outcomes were complete remission of neoplasia at 3 and 12 months. And this is an image taken from that article. And the outcome was that at 12 months, the eradication of neoplasia was 84%. So that was also quite convincing. Keep those 78 patients in mind, and then I can show you a subsequent study. We went back 5 years later and studied the patients who were in complete eradication at the 12-month follow-up in the primary study, and we wished to find out what the long-term outcomes were. So these are the 78 patients in complete remission after 12 months in the initial study. And 67 out of those 78 were, after 5 years, still in a complete remission. There was recurrent disease in 9%, and there was progressive disease in 5%. But we also reviewed the charts of the patients who had a treatment failures, and those 12 patients with the treatment failures received additional RFA in the subsequent month. And 6 out of 12 were in complete remission after 5 years, but there were 6 with progressive disease. And amongst those recurrent or progressive diseases were very, also advanced cases of cancer. And the most worrisome feature is shown in this image, also published in the paper. There were 2 patients, and this is one of those 2 patients, who initially had a lugal voiding area here with a pink color sign here, treated with RFA and treated again with focal RFA, and then turned into complete eradication. But during follow-up, a small nodule developed, but that was completely normal after Lugol staining. And this nodule turned out to be a poorly differentiated cancer covered by normal-looking epithelium. So a sort of buried cancer. And you can see the histological corresponding image here with a normal squamous lining and cancer in the deeper layers. And this is frightening because then progression is not noticed during follow-up endoscopies. And there's an explanation for this phenomenon, and that is that in squamous epithelium, there are submucosal glands which are attached to the mucosa through submucosal or through ducts. So those ducts connect the superficial epithelium to the glands which are located quite deep in the submucosa. And it is possible for dysplastic cells to follow the basal membrane of the ducts all as deep into the submucosa, still being non-invasive, but being located in a very deep layer here. And if you have an ablation tool which ablates approximately until this level to the muscularis mucosa, then you can imagine that this area, which is at this moment in time still not an invasive cancer but only dysplasia, can develop into an invasive cancer which is not visible during follow-up endoscopy. And this is a real problem. We have evaluated ESD specimen of flat type esophageal squamous neoplasia in a cohort of 65 Japanese patients and 14 Dutch patients. And ductal extension of neoplasia, or extension into those submucosal glands, was seen in 58%. This again is another example. You can clearly see here the involvement of the duct, which is probably connected to this gland here. So in 41%, no ductal extension. And Almost exactly the same distribution was found in not Eastern patients, so Western patients, Dutch patients. So our next step was to try to further evaluate this in an animal study using RFA, both circumferential and focal, and cryoballoon ablation in an animal model. And this is an example of balloon RFA, where you can see a submucosal gland here, which is still vital after ablation, superficial ablation of the esophageal lining here. So in this case, this submucosal gland was not killed by RFA. And we saw that in 33%. Cryoballoon ablation, however, resulted in a much deeper ablation. And here you can see a focal ablation. This part was ablated. This part was not ablated because the ablation was until here with a clear demarcation. This submucosal duct gland in the non-ablated area is vital, and this submucosal gland in the ablated area was completely dead. However, the same was true for focal RFA, so with the Barracks 90. Here again, non-treated and treated, a vital submucosal gland and a dead submucosal gland. So, ladies and gentlemen, I would like to come to conclusion. Cryoballoon ablation has potential advantages in ablation of Barrett's esophagus-related dysplasia. It is shown, and I think that is also compatible with the experience of those who perform cryoablation, it's less painful. It might allow for deeper ablation, and that might have some niche indication, and hopefully it's cheaper. So what are the potential niche indications for cryoballoon ablation? Well, maybe RFA refractory cases, question mark. Maybe salvage ablation in R1 or Rx, double question mark, so this really has to be proven. And a triple question mark in selected cases of esophageal squamous cell neoplasia. But, and this is how I would like to end my presentation, as always, more research is needed. I thank you very much for your kind attention. I'm very happy to take any questions.
Thank you so much for that excellent overview, Professor Voisten. Before we go into the Q&A, I'd just like to introduce and welcome back Rehan Haidari into the studio, but also Professor Lawrence Lovett, who is a consultant colleague and mentor of mine. So it's great to have you all with us today. So Baz, I'd like to ask you the first question. That was a really elegant overview of the subject field. And one of the proposed additional benefits of cryoablation, given the mechanism of cell injury, is we would hypothesize there to be less strictures. Now, that's not something that's really been borne out in the evidence so far. And if anything, it's comparable with RFA. What are your thoughts on that? And are there any measures that you take to reduce that when you offer this therapy, Baz?
Well, that's an excellent addition indeed. We hoped indeed that cryoablation was associated with less strictures than RFA, but both in the study I showed from Mimicanto, the prospective series, as well as a current study we're currently running and where you are participating in as well, and the Euro Coldplay study on cryoballoon ablation in European patients with Barrett's, we end up with approximately 10% stricture rate, and that is similar to what we see in our RFA. So theoretically, yes, there might be less stricture because of the preservation of the extracellular matrix, but in practice, I'm afraid it's not the case. I'm not sure whether there are precautions to minimize the risk of strictures. Obviously, you should try to avoid too much overlap between ablations, and that is a little bit more difficult in cryoablation because it's more difficult to see the ablated area compared to RFA. But beside that, I don't think there are any precautions you can take to minimize that risk. I think that's the way it is. We have to live with it.
Yeah, hi Buzz, great talk. It's Rehan here, good to see you and thanks for making the time. I think we just need to be a little bit guarded in using strictures as a comparator for the two techniques. Stricture formation after ablation in any ablative modality is multifactorial, and there's a lot of confounding here when you try and compare these things. You're comparing apples and pears in terms of site, the extent of endoscopic resection, the ongoing refluxate, acid suppression post-ablation. So, of course, we need to be cognizant of the fact that we don't want to introduce a new ablative modality to the shelf that has an unsafe stricture rate. But I think that I've heard a lot, but the stricture rate may or may not be X, Y, Z. I don't think that should be a comparator. It should be more based on disease remission, perhaps recovery post-procedure, and as you said, cost effectiveness. Let me just go a bit off piece here. I like your three sort of niche indications there in terms of other indications where it might be used. There's a bit of emerging practice now in the context of recanalization of malignant strictures and tissue debulking. Your thoughts, because we've used it there with some really good outcomes, and 1 or 2 sessions can be the difference between a stent or no stent.
Did you use the cryo balloon ablation for that indication?
Yes.
Oh, that's great to hear. I have no personal experience. I know from experience of US centers who use it with the cryospray technology, and that looks promising. So I would be very keen to try it on our patients with the cryo balloon, but I'm not sure whether the balloon is stable in a strictured esophagus due to a tumor, but I would like to learn from you here.
So Baz, let me, and I'll bring this to Lawrence in a while. So Euro Coldplay will report imminently, and you've completed recruitment, and the interim analysis are really good. Mimi's study from last year, the year before, is encouraging. We've got comparable rates of disease eradication, very similar to what we had 10 years with the early studies in RF. So we've got the German trial last year looking at hybrid APC. So what's the pecking order in terms of ablative modalities? Is there one? And where will cryo fall into the algorithm moving forward?
Yeah, that's an excellent question, and I was a little bit afraid that you would ask that question. Well, to be honest, on RFA there is a huge amount of very solid evidence that also on the long term there is a high effectiveness with a very reasonable safety profile. And it's very hard to compete with that bulk of evidence for newer ablation technologies. Having said that, it would surprise me that given the results we have seen from the cryoablation now, that it would on the long term be disappointing. So and the same is with hybrid APC. So I think it's a matter of a personal preference, a matter of cost, a matter of patient preference as well, because we really impose a considerable burden on our patients with RFA, because, well, I only realized when I did the study, I always send them back for 3 months, and after 3 months patients have forgotten how severely they suffer their pain. But if you really investigate it on a systematical fashion with diaries, which we then used for study purposes, then it's really a significant burden we impose on our patients in terms of pain. So I think that might be one of the factors that you can take into account as well. But once again, the most solid proof is for RFA, and it is very effective. It is very effective even in less experienced hands. So that's I think that's a
safe answer. Thanks, Buzz. Lawrence, let me come to you. As you fronted up a lot of the PDT studies a while back, and and then helped to introduce RF into the market here, and more than 10 years ago. So, as a sort of RF purist, so to speak, when you listen to this and when you hear these debates, are you agitated, or are you quite comfortable in your space?
Oh, I'm very comfortable in my space always, but I do wonder whether we are perhaps clutching at straws. We're trying to find a little niche which is going to allow a new technology to blossom. You're right, I'm a bit long in the tooth, right? And I'm sort of listening to this thinking, cryoablation for tumours, but we used to use a YAG laser very effectively. We're reinventing the wheel with another modality, and I'm not convinced that that's actually going to benefit us at all. As far as dysplastic Barrett's is concerned, I think the story's more a slam dunk actually with RFA. I'm not convinced that cryo is going to really be able to push RFA out. It might be an adjunct in those very small number of patients, but actually a lot of the patients where RFA doesn't quite work are old, they've got comorbidities, and actually they'd be quite happy just to undergo surveillance, because remember, you've only got a 20% risk at 5 years of getting new cancer after you've already removed the first one.
I think I completely agree with you. I think the only consideration, there are sort of geo-logistical issues here as well in terms of cost. They are undoubtedly regions or centres outside of the UK, the Netherlands, Europe, where perhaps an investment in an RF generator and the catheters, as you well know, it's not an insignificant undertaking, and I think that's...
But do we know what the price point will be for cryoablation? Has that been set yet? I'm not aware it has it?
But anyway, the answer is I don't know.
Because I remember a few years ago having a conversation with some of the people in the cryo space from the commercial side who were talking. I said, fantastic, it's going to be really cheap. This will knock RF out of the market. And the answer was, no, we're going to put it at the same price point as RFA. So I think these are really important considerations. And I hope if anybody from the commercial world is listening, please make sure it's cheaper so that it actually becomes more democratically available.
Thanks, Lawrence. Look, I think at this moment we're going to just show a case demonstration here of a patient that's been treated recently with cryoablation, just to go through a few learning points here. So if we can play that video. So this is a 61-year-old gentleman, with a M5 segment of Barrett's, had previously had a mucosal resection which revealed high-grade dysplasia. Interestingly, and leading on from Baz's final points, this patient was refractory to RFA, so perhaps there is a space here for this therapy. So the video will be demonstrating the case using a Pentax I10 gastroscope. Importantly, you need a 3.8mm working channel to get the device through, so please bear this in mind. And we'll be using the Pentax C2 cryoablation system. So if we can roll the video. So while we wait for that to get started, I'll just talk through some basics. So before you do any ablation, before you put anything down, have a good look. You don't want to miss a visible lesion, and that's why you want to have a careful inspection of the cardium and retroflexion. So this is the balloon device. You can see when you get the catheter down, there'll be a gold marking. That's where you want to inflate your balloon at that point. So what I'm just doing here is just working out my location, and sometimes a balloon can slip. So you really want to be very careful, and there you go. So now that your balloon is right opposed against your scope, you get a very, very nice real-time visualization. There's these important iterations on the device itself. So you have these circled dots, which are basically parallel to where the device will fire, which is a good improvement and helps us reduce the chance of over-treating these patients. And you can see one of the main benefits of cryo as well is you get a real-time visualization of your treatment effect. So you can actually see what you're doing in real time. There's also going to be less intubation and extubation as the device is all pushed through the scope itself. And I'm just very carefully working my way around, down from the 1 o'clock position now down to 4 to 5 o'clock. And with a bit of experience, you can actually become very targeted in your therapy. And what I'm going to demonstrate here is, I think I've missed a bit there at the 3 o'clock lesion, and I'm just going to treat that there. So there is a risk of overlap, of course, but you are getting a really nice targeted ablation here. And we'll work our way round down to the sort of 7 o'clock position there. And bear in mind that the treatment effect will spread. So try to anticipate that. What I've also found quite useful sometimes is to do some marking before the therapy. I haven't done it in this case, but you can use APC to mark before the oral and anal margins so that you don't over-treat these patients. And you can really work pretty closely actually. So what I'll do here now is bring the diffuser quite close to the scope and treat this area immediately below me here. And this is all operated with a very simple to use foot pedal, and the actual handheld device is much smaller than those large sort of cumbersome RFA generators, so very portable. And that is one of the proposed benefits of it.
When you press, how long does it give the cryo for?
So a bit of dosimetry work's been done on this, and we've reduced the dose down to 8 seconds based on a slightly higher than expected stricture rate at 10. So we're down to 8 seconds now. And important to say, patients need to follow the same post-ablation protocol. So this will show you how different the ablation effect looks immediately when you compare it to RFA. So within a few seconds, you'll actually lose that white coagulum, and actually you'll just see this dusky purple hue, which I would just say is synonymous almost with bruising. That is a treated segment with cryo, and you've got to be sort of cognizant of that and be aware of that so you don't treat over that area again, which is easily done. Yeah. And there is a learning curve to it, and I would say that the learning curve is probably slightly steeper than RFA, and that may limit uptake, as we discussed earlier. Patients, and as Bars made a really good point, we don't tend to ask these patients about pain immediately afterwards. With RFA, we send them home and we see them again in 12 weeks' time. But it is an issue if you look into it, and cryo seems to be really helpful in that regard. Do you have any tips or tricks, Rehan, for cryo? Because you trained me how to do it. But what are if someone's wanting to get started in doing cryoablation, what are the sort of things they should bear in mind? Do we treat long segments? Does it matter how long the segment is?
Oh, I trained you and Bars trained me. So, look, I think as with anything, you don't want to overtreat these patients, because when you're starting off, I think that there's 3 considerations. So as with any new, first of all, get to know your device. Spend some time with your techs to understand how the gun works, understand how nitrous oxide canisters get loaded and unloaded, and also know what the various error messages mean, if there's a kink catheter, if there's a low balloon pressure. And then know what your different balloons are. The balloon you've just shown there is the straight firing balloon. There's now a pear-shaped balloon, which is very good because it's almost like an hourglass for treating across strictures. And then that will help you to make a more sort of targeted decision in terms of how you deliver your therapy.
Can I just ask Baz, the pear-shaped balloon, right? I've not seen it, but one of the big problems with RFA is when you are treating across strictures, which is very difficult to manage. How well do you find the cryo system works when you've got a patient who's already got a stricture, probably post-EMR?
Well, a wheel stricture is also difficult with, I've got an enormous echo in my ear. Yes, thank you. A wheel stricture is difficult with cryo as well as with RFA. The benefit of the pear shape is especially at the GE junction. After a limited endoscopic resection or just the GE junction, it's much more stable in the GE junction than a regular shaped balloon. But a real nasty stricture is as difficult to treat with cryo as with all other modalities.
Below and just leave the stricture untreated?
Sorry, once again?
Can you treat above the stricture, below the stricture, and then leave the middle bit untreated, which would be quite a nice thing to be able to do?
Well, I think that depends on the nature of the stricture. It's difficult to give an answer in general here. What I more and more do in Barrett's adjacent to strictures is just treated with APC. That's what I usually do. And if the area is a little bit larger, then I do some injection and treat it as hybrid APC, but with a poor man's hybrid APC, injecting it with a needle and then ablate it with a cheap APC catheter.
There's nothing wrong with that, but Vinay was just asking, tips and tricks. I think the other thing that if you're starting off and you have anatomical problems, Lawrence, is you don't have to automatically inflate the balloon. There is a manual function. Right. With a 50 mils Luolox syringe, you can actually bring the balloon up so that it doesn't slip across. You then run a slight risk in terms of tissue contact, but that is an option to help stabilize the balloon. So Vinny, look, I think that it's an exciting technology. I think that it will be here to stay. It's we're going to have very hopefully high quality prospective evidence coming out in the coming months. And I think it will be an adjunct. I think it'll help in these refractory cases where often, there is the alternative is not a handsome alternative. Surgery is not something that you want to consider. And I think there will be these niche cases. I think that the one thing that I wanted to touch on to Baz and to Lawrence is because we've skirted around this issue of squamous dysplasia and ablation nervously as Western endoscopists. And I think this morning's session really consolidated the fact that, endoresection and ESD is the standard of care for squamous dysplasia. Yet every now and then there is a small series published from China. We Baz, you and Jacques published on RF, what Lawrence and I did back in the day. No, but we published that. We published that 10 years ago. Yeah. There's been nothing since. No. But we've just lost Baz. But there you are, Baz. So 2 years ago there was a study from China, I think, with your group and with Professor Wang, select patients with flat lesions, and then you published the follow-up series as well from the RF trial that you did, when Lawrence and I did our first trial. You think there's any traction to this story, or we can put this to bed that actually this is not something we should be even thinking about? Because I still get the odd referral, I get the odd phone call from a colleague to say, I've got a patient with a small plaque, can I do RFA on it? Would you accept them for cryoballoon therapy?
Well, I think that the data so far is not supportive of using any ablation technology for squamous. And of course, there are situations in which you don't have an alternative. We all know those cases, patients in a poor health condition after chemoradiotherapy with still some dysplastic area. You can even doubt whether you should ablate it and not just wait until the patient suffers from other diseases and die from that. But every now and then I have a patient who I treat with cryo, but the message should be that all squamous neoplasia should be resected with ESD. Yeah, I think with ESD.
Brilliant. Lawrence, is that your message now as well with RF?
Our experience was poor, and nobody else seems to have got any better experience. So I think that message is pretty clear, yes.
Right. So look, I think we could carry on with this, but we're going to need to move on for the interest of time. And we're going to go into another case now, demonstrating RFA in Barrett's. So this is a 72-year-old gentleman with a long segment, 8 centimeters of Barrett's. Again, he's had a previous mucosal resection, which was revealing of a moderately differentiated intramucosal adenocarcinoma, no poor prognostic features. So he's come back for ablative therapy. The kit on demonstration is a Pentax I-10 gastroscope and an RFA ultra-long catheter by Medtronic. So if we can go to the VT, please.
What you can see here is at the south of the picture here is the squamous island of the scarring from his EMRs. Now, the fact he's healed with squamous tissue is a good sign that he'll hopefully respond therefore to therapy. Patients who heal with Barrett's tissue or columnar line tissue often is a poor sign in terms of their response to therapy. So that's a good sign there. Now, okay, Chris, spray for me, please.
Okay, spraying.
And we're just spraying N-acetylcysteine all over the Barrett segment. This is the Medtronic radiofrequency ablation ultra long device. It's 90, but it's 4 centimeters long, which allows you to do long non-circumferential segments. So attach it to the scope, wet it, and wet the scope. Don't use gel, as it decreases the efficacy of the ablations. Just wet both, and then very simply shove the device onto the scope, making sure you grip at the sides so that you don't damage the catheter. And you want it to go all the way on you can no longer see any of the rubber. And you want the device to be at the very top of the picture like that. Do not connect the catheter until you're inside the patient's esophagus. Again, don't use gel, just use water. So what we're going to demonstrate here is using the dye spray catheters to railroad down the radiofrequency ablation device. So you can see we're intubating in the same fashion. We then sit above the esophagus here. Andrew, just put the scope for me there. We then use the dye spray catheter to go down into the esophagus as such. So that is now acting as a railroad down into the esophagus. And we then follow that down. Instead of following that down, sorry sir, bear with me, into the esophagus there. And that can sometimes just help you down if you've got a tricky intubation. And we can take that out for me, please guys. Perfect. So the dosimetry here is a 12-12. And what that means is you find the gastroesophageal junction, which is here. Big wheel comes all the way up and suction. And then 3 presses of the pedal without moving. Wait for the ablation to be delivered. You'll hear that beep at the end. That means it's been delivered. Once it's been, the third one has been delivered, just come away from the esophageal wall. And that stretches out the esophagus. And then you use your right hand to rotate by torquing the hand to minimize overlap. Find again the gastroesophageal junction. Big wheel up and suction and deliver. You can see the whole of the bats has been treated successfully, and we can stop there today. That's good.
Okay, thanks a lot for that, Dave. That was a nice demonstration there of the Halo Ultra catheter. I'm just going to come to you, Lawrence, at this point. Can you talk me through your decision-making process in deciding which size catheter you're going to use when you are approached with a patient that you're about to ablate?
Okay, so you've got multiple lengths of catheter, yes? You've got an incredibly tiny one that you can just put through the endoscope. You've got, the trouble is they keep changing the names, but there was the Halo 60, then the Halo 90, and the Halo 90 Ultra, which essentially are just bigger and bigger and bigger. That was what I call the Halo 90 Ultra, but it's essentially, it's 4 centimeters long. And then, of course, you've got the one that does a circumferential, the Express. The longer the segment of Barrett's, the bigger the thing you're going to use. And you also have to be aware as whether the patient's got a stricture. Often people have asymptomatic cricopharyngeal spasm, and you don't realize it until you try and put one of your catheters down. So the Express, which is literally a catheter that's very, very small and will open up inside the esophagus, may be useful in those sorts of patients, particularly in their first procedure. So first procedure, long segment Barrett's, you may think about using a circumferential technique. Truthfully, the mean length of Barrett's is 5 centimeters. So most patients are going to have less than 10 centimeters of Barrett's. What you just seen there with that extra long catheter, it's 6 goes to do an entire circumference, and if you do that at 3 levels, you've got your 10 centimeters. It's quicker and easier, in my mind, than putting a circumferential catheter in, particularly as often the esophagus is not quite straight, and when you use the circumferential one, it doesn't quite get all the walls, whereas with this, if you're good at it, and it doesn't take that long to learn, you can actually make sure that you have got good contact all the way around the esophageal wall. So I tend to go more with focal devices, even for long segment Barrett's these days.
And we know that the ablation really only works if we eliminate the acid in the background. Are you able to talk me through your protocol for post-ablation patients, just to remind everybody?
Yeah, I'm not sure I know the protocol. I only ever find out what I should have done when I come back and look later and discover the patient hasn't actually healed the way I wanted them to. But essentially, high-dose acid suppression, so esomeprazole 40 milligrams twice daily before meals, always before breakfast and before supper, and that's sort of the background. And then in the 8 weeks or so after an ablation event, particularly in patients where the previous ablation has not been nearly successful as you expected, I like to give them sucralfate, something with bismuth, which will work to coat the lining of the esophagus and reduce the risk of acid coming back. And of course, the big important thing here is you have to make sure it's at different times the esomeprazole, because otherwise it stops the esomeprazole working. So at least, so I say esomeprazole before breakfast and supper, sucralfate liquid at lunchtime and bedtime.
Let me take you forward a few steps then, and maybe this is something quite close to your heart, Bars. I remember the days where we were eradicating the Barrett's and then sampling the baseline segment. Very cumbersome, very time consuming, and we've moved away from that, and we know that the sort of trigger zone for dysplasia recurrence is more on the distal esophagus than if not the cardia. But Bars, I know that your group has recently published saying we can get away from this and forget random biopsy sampling at the GEJ. Are you able to tell me your thoughts about this?
Well, you can get away with it if you are a very good endoscopist and have a very close and detailed and good look at the GE junction. And so I don't think we should advocate to leave out those biopsies from the GE junction after ablation in all centers. But if you're really an expert center, and if you really are able to do a good imaging of the esophageal gastric junction, then we showed that in that situation, random biopsies doesn't add anything to your clinical decision making and to the prognosis, as long as you have a low threshold for biopsying areas where the mucosal pattern is not completely regular.
Lawrence, do you want to add something?
Yeah, well done that you're able to, in your expert centre, identify when you don't need to take a biopsy. And I think this needs to be really rigorously looked at, because some years ago, I actually compared a few of us in our centre as to how well we could identify dysplastic Barrett's. And there was a wide variation, even in an expert centre like ours. And I think I was one of the worst, by the way, so I'm allowed to say that. But it was interesting that it was hard to detect subtle lesions. And I'm still surprised, I really am still surprised, after 20 odd years of doing this, that I still can't necessarily interpret what I'm seeing. And I always have a slight suspicion when other people say they can interpret. I think they're probably over-interpreting. In other words, they're saying they see more dysplasia than they really do. But I'm not comfortable with this.
But I think in the context of what we're discussing, which is where to sample post-therapy, the data are pretty accurate now that actually random biopsies of the neosquamous, of the regenerated squamous mucosa is the positive. It's very low.
Very low. Very low. We've all seen that.
So
That's for sure. But my worry is around the OGJ, where you do get the recurrent dysplasia, or where you see a tiny little focus of Barrett's. Often, it's really useful to use narrowband imaging, because you see these tiny little foci, and if you bother to biopsy them, some of those will actually be dysplastic.
And then I think we're all still advocating that we biopsy in that area. Let me just pull this back a bit, because this morning we talked about management of cancer, and now we're talking about ablation for high grade and residual metaplastic Barrett's. But we've sort of shied away from talking about low grade dysplasia. We get a lot of referrals. I get a lot of referrals. The incidental biopsy of just amounting to low grade dysplasia in a young and fit patient with an average size Barrett segment. And there is discussion. There is our own guidelines changed in the UK to advocate that perhaps we should be a little bit more lean more towards intervention rather than vigilant surveillance. I have my own view on this, Baz. We've talked about this over a coffee. I think perhaps we overtreat these patients. What is your practice? What are you doing with low-grade dysplasia in your centre, and then you might open that up to the other panel members.
Well, in the last couple of years, I moved a little bit away from ablating all patients with low-grade dysplasia. Most patients, and it's important to realize, most patients we treat with Barrett's are of older age and have comorbid disease. And the likelihood that they will die from something else than esophageal cancer, if you leave a low-grade dysplastic Barrett's untreated, is much higher than they die from cancer of the esophagus. But of course, there are situations of patients in whom are really ablate patients with low-grade dysplasia. If you're young, if you have a positive family history of esophageal adenocarcinoma, especially if the low-grade dysplasia is repeated on several endoscopies. So there's no, it's not a bad decision to treat patients with RFA or other ablation methods if you have low-grade dysplasia. But I think it should be a balanced decision, taking into account the comorbidity of the patient, especially that, and the cost. And also, it's not a free treatment, because there are costs associated with it, but once in a while you end up with a relatively difficult to treat stricture, and I always am a little bit well, I feel sorry if I cause a stricture in a patient with only one biopsy of low-grade dysplasia, then I think, well, I didn't do any good to this patient. So it's I think a patient-tailored approach, but the tendency is to ablate less than I did a couple of years ago.
That's a really elegant answer. I think you've covered everything there. One is that, of course, societal guidance is exactly that. It's guidance. But, we published our cohort of low grades with Dr. Hussein a few years ago, and we certainly found that, unifocal low-grade dysplasia was one very rarely reproduced, or when it didn't progress compared to multifocal low-grade. But our practice is also one of extreme caution with these patients.
Can I just sharpen that a little bit? The way I think of it is, if a patient comes in and you found they have low-grade dysplasia at endoscopy, the first thing is A, to histopathologists to review as per societal guidelines, B, bring them back for a second endoscopy and confirm the low-grade is still there. And we know that 80% you won't find it a second time round. And once you've got low-grade dysplasia confirmed by 2 histopathologists on 2 consecutive endoscopies, the likelihood that that patient will progress to high-grade dysplasia or cancer is very similar to that of high-grade dysplastic patients. And in fact, many of these so-called low-grade patients end up having a focus of high-grade as well. So I would suggest you actually can differentiate your low grades into the low-risk low grades, either have it once and they probably don't have it again, or not for another year or 2 or 3, versus those who have persistent multifocal, and they're those you really should treat.
So this is a really, as you can see, controversial space, and I think there's a lot of debate here. I think in the interest of time, we're going to have to move on to the next recorded lecture. That's by yourself, Lawrence, discussing the long-term outcomes of radiofrequency ablation. So can we please play the presentation?
Hello, ladies and gentlemen. My role today is to talk to you about the long-term outcomes of radiofrequency ablation in Barrett's esophagus. But before I do that, I'm quite keen just to take a step back and think about the historical background. Now, of course, we've been talking today about making sure that you can detect your area of dysplasia. So this is a combination of your visual inspection and confirmatory pathology. And ideally, you want to see a biopsy sample that looks like this, where you can see neat glands with intestinal metaplasia and the goblet cells. And you don't really want to see the back-to-back glands with the enlarged blue nuclei, very typical of high-grade dysplasia as shown here. Because until only a few years ago, the standard treatment for such a patient would be to undergo esophagectomy. And esophagectomy is a pretty awful thing to have to do to somebody where you're trying to prevent a disease rather than cure one. And the reason for that is simply that the whole mortality rate 15 years ago was almost 5%. It's dropped to 1.9% by 2015, and it's about 1.5% now. But nonetheless, if 1 in 15 patients who's being given a treatment to prevent a disease is going to die as a result of that treatment, that's a very difficult thing to deal with. And it's certainly more than simply a sledgehammer cracking a nut. So the whole premise of endoscopic therapy is that you can remove the abnormalities without having to do major surgery. But still you have the issue of visible lesions. And when you have a visible lesion, the principle remains to remove that lesion. And of course, the standard way of doing that is endoscopic resection. And the reason for so doing is partly to flatten the mucosa, but also that you can assess the depth of penetration of your lesion. Does it go through the mucosa into the muscularis mucosae and beyond into the submucosa? And if so, that then becomes a non-endoscopically treatable lesion. But presuming that it is endoscopically treatable, then endoscopic therapy would be the ideal way forward. And this paper from 2008 really made the point. It's the only really good evidence we have for what we're going to discuss in a minute, but that is the eradication of the residual Barrett's with ablative therapy after endoscopic resection reduces the risk of metachronous neoplasia, in other words, cancer occurring later on. And we know that from this paper, there is a 20% risk of cancer developing within 5 years from a lesion, an area of Barrett's esophagus which has had endoscopic therapy for a dysplastic lesion. Furthermore, the vast majority of patients undergoing that endoscopic resection will have high-grade or potentially low-grade dysplasia detected in the rest of the Barrett segment. Now, what we want to do is to ablate the rest of the Barrett segment and to get rid of not only the dysplasia, but the Barrett's itself. And there are various ways of doing this. We're going to talk about radiofrequency ablation, and the appeal of this is that it literally only treats about 500 microns in depth, the depth of the mucosa itself. There are, of course, other treatments, argon plasma coagulation or cryotherapy, for example, which can treat deeper into the submucosa. Endoscopic resection, of course, even when doing what many people still call an EMR, an endoscopic mucosal resection, will actually take out some of the submucosa, and that's part of the reason patients may run the risk of getting stricturing after endoscopic resection. And of course, surgery removes the entire thickness of the esophageal wall because you're taking out the entire esophagus. And the real key attractions of radiofrequency ablation is you get uniform removal of the mucosa and you get a controlled depth of ablation. And that is different, I think, to any of the other heat or cold-based therapies that you have available. Now, the pivotal randomized controlled trial of radiofrequency ablation was published in 2009. This was the AIM dysplasia trial. It was a randomized sham control design where the majority of patients underwent RFA, but one in 3 patients had a sham procedure. Patients were stratified by degree of dysplasia, low versus high grade, and the length of segment, whether it was shorter or longer length of segment. But notice that in this trial, the maximum length is only 8 centimeters, whereas in real life, there are many patients with rather longer Barrett's than that. Up to 8 centimeters was a maximum of 4 radiofrequency ablation sessions given. The sham and the treated groups both had identical biopsy protocols with equal sampling. Now, it's also worth noticing that in this trial, about 10% of the patients, that's 10%, had had endoscopic resection prior to undergoing radiofrequency ablation. And you'll note that on the intention to treat arm, we'll just look on this side of the graph, almost 20% of patients who had sham treatment actually had apparent complete response of dysplasia, which just shows you how difficult diagnosis of dysplasia certainly was at that time, although it's perhaps a little bit easier these days. But nonetheless, 81% of the patients who were treated with radiofrequency ablation had response of their dysplasia and a complete remission of the high-grade dysplasia at 1 year with maximum of 4 treatments. And that's a number you need to treat of 1.3 patients to get a benefit. For Barrett's, not surprisingly, none of the patients who were not treated had any reversible Barrett's, but 77% of the patients who underwent radiofrequency ablation had reversal of their Barrett's segment. It came at a cost. 6% of patients developed esophageal strictures, and most of those strictures actually resolved within a mean of 2.6 dilatations. So the patients who did get strictures were able to get a relatively straightforward therapy for that complication. Perhaps more importantly than anything is the likelihood of disease progression. And patients who had high-grade dysplasia, if they weren't treated, at 1 year they had a 19% risk of progression to cancer, which I should point out is a very high risk compared to other studies. The other studies that have actually looked at this have shown about 8% or 6%, but nonetheless, in this group it was 19%, and in those who had the RFA, it was only 2%. There was a 90% reduction in cancer progression. Similarly, low-grade to high-grade dysplasia was at a lower rate at this point. Now, this led in 2013 to a complete change, whereas until that point, anybody with high-grade dysplasia was treated surgically, and patients with low-grade dysplasia went into surveillance. At this point, the British Society of Gastroenterology mandated that for high-grade dysplasia with neoplasia confined to the mucosa, endoscopic therapy is preferred over esophagectomy or surveillance. And furthermore, endoscopic resection should be considered as the therapy of choice for dysplasia when there are visible lesions or for intramucosal adenocarcinoma. But low-grade dysplasia, the recommendation still remained at that point to continue to do surveillance. However, the following year, this important trial, the second randomized controlled trial, but specifically in low-grade dysplasia patients, was published. This is from the Amsterdam group, and showed that RFA resulted in reduced rate of neoplastic progression in patients with low-grade dysplasia. And you can see that in the 68 patients in each group, ablation, there was virtually no progression to high-grade dysplasia or dysplasia, whereas the controls, at 3 years, there was about a 30% progression rate. Note that progression rate in low-grade dysplasia is almost identical to progression rate in high-grade dysplasia, which is quite interesting in itself. But also note that the vast majority of patients with an initial diagnosis of low-grade dysplasia were actually downstaged, and only 1 in 5 patients who were originally screened for this trial ended up getting treatment. And this makes the point that we also need to remind ourselves that low-grade dysplasia is a very difficult diagnosis, and it remains so to this day. Now, the National Esophageal Gastric Cancer Audit has been looking at high-grade dysplasia since 2015. And what's quite interesting is how things have developed over the last few years. So by 2015, with patients with high-grade dysplasia, about 2/3 were getting endoscopic therapy. 6% were still having surgery as first choice, even though the guidelines had changed, and still 1/4 of patients were undergoing surveillance. If you look what's happened, and these are the annual reports, and the latest report actually shows, it says 2021, and I apologize, that should be 2023. This is literally published last week. Shows that endoscopic therapy went up significantly over a few years, but dropped due to the pandemic. Curative surgery rates fell, but there are still people who are undergoing curative surgery as a first line treatment. Surveillance dropped, but unfortunately has gone back up again. I guess there are people who have not wanted to treat high-grade dysplasia patients. There'll be more important patients to treat during the pandemic. And again, the number of patients undergoing surveillance alone started falling and then started coming back up again. Again, presumably there are centers that don't want to be treating patients. What's also interesting is that the latest report from the National Esophageal Gastric Cancer Audit has shown that about 3/4 of patients are undergoing endoscopic resection as their first line treatment. But there are still over 20%, 1 in 5 patients, who undergo some sort of ablative therapy initially because it's simply not possible to identify the precise location of the dysplasia, despite having excellent imaging techniques. And the final point I just want to make, which I think is really interesting, and this was reported in 2021, but not in the latest guidelines. The BSG guidelines, the British Society of Gastroenterology guidelines for a specialist centre, was defined as one which treated 15 patients per year, and yet only 20% of centres, 7 out of 36 UK centres treating high-grade dysplasia, actually met this standard in 2021. Again, this has not been re-reported for the current year, but it is interesting that we are struggling, even with centres which have 1.5 to 2 million population of catchment, the number of patients that are actually being put through these centres is not enough to get 15 patients per year treated. Why 15? Well, we can talk about that a little bit later. So let's just move on to our real life outcomes. So treatment of Barrett's esophagus neoplasia in the UK has really been driven by real world knowledge. The first case was done by myself at UCLH in 2007. That's 16 years ago now. Dr. Hadry joined me thereafter, and we started the RFA registry in 2008. And initially we had 6 specialist cancer centres on board. Our registry was then adopted by NICE in 2010, and eventually we ended up with 28 centres around the UK contributing to the registry, and we enrolled 2,500 patients in the first 10 years of the registry. The treatment protocol is, of course, very important, and it's pretty obvious that you first have to diagnose your lesion, you then do your endoscopic resection if possible, and then you do the radiofrequency ablation. And the radiofrequency ablation aim is to completely eradicate the Barrett's esophagus, so that you end up with squamous neoplasia. And as you can see, this is quite interesting. This patient was completely asymptomatic, but you can see there is also an asymptomatic mild stricture in the distal esophagus. And this is actually very common, much more than the 6% I told you about before of patients with symptomatic strictures. Protocol, absolutely crucial, and it took us a while to get this right. But you have the primary RFA procedure. 3 months later, if there's visible Barrett's, you have another RFA. If there's no visible Barrett's, and you take biopsies, if there's Barrett's histologically, you still have another, you come back for another RFA. If there's none, they go into regular surveillance. And all the patients then underwent endoscopy and biopsy at 12 months, and then went into long-term surveillance. And this was the first paper we published. The initial treatment algorithm was unclear. Our patient selection was also poor. And what we found initially was that we were getting dysplasia responses of 64%, which is more rather low than the AIM dysplasia trial. But over the coming years, we managed to improve that. So up to 79% within a year or two, up to 83% by 2012. And we're now up to 88%, where we get complete eradication of dysplasia. The complete eradication of Barrett's esophagus itself lags somewhat behind that. When you compare high-grade dysplasia here in green with intramucosal adenocarcinoma in blue, interestingly, although the IMC patients required more endoscopic resections before starting the RFA treatment, nonetheless, the outcomes, certainly at 5 years, look to be pretty much identical. Now, durability, of course, is all, because initial eradication doesn't tell you that it's going to work long term. The original AIM dysplasia trial reported 3-year follow-up. And you can see for dysplasia and for Barrett's esophagus, it appears that the relapses tend to occur early and then seems to hold up quite well. And in the high-grade dysplasia cohort, there's an initial 10% or so drop off, and then every year another 5% seem to drop off in years 2 and 3. So it's pretty good, but not perfect. There was a later paper in 2017 giving you the final 5-year data from the AIM dysplasia trial, and it appeared that the low-grade dysplasia patients continue to recur until 5 years. The high grades, if they were going to recur, recurred early, but still there was about a 40% failure rate in that group. There was a systematic review which was published in 2021, which actually found 8 studies now looking at long-term outcomes. And despite high efficacy at baseline completion, apparently 96% eradication dysplasia in these trials, it declined to 89% over 3.5 years of follow-up that they had, but only 2 studies reported follow-up of more than 5 years. And certainly there seemed to be higher, longer follow-up seemed to correlate with decrease in efficacy, which is why we're really pleased that we were able to report the final data from the UK RFA registry a few months ago. Now, we looked at over 2,500 patients with almost 20,000 procedures, and we have adequate long-term data in 1,175 of those patients, half of whom are high-grade dysplasia, half intramucosal cancer, and the other half low-grade dysplasia. And we found that it took up to 2 years actually to get rid of the dysplasia. Some patients needed more than the 4 treatments, particularly those with longer segments of Barrett's esophagus. And the CRD, the complete response of dysplasia at 2 years was 88%. And for Barrett's itself, the complete response of intestinal metaplasia was just under 2/3 at 2 years. But this is really the most important single slide in the whole of this talk, and that is that at 10 years, from the entire 2,500 patient cohort, we were able to follow them up, and we found that the 10-year cancer risk was actually only 4.1%. Notice that this is a very expanded scale, and it's truncated at 80% here. The 10-year cancer risk is only 4%, whereas the historical cancer risk was actually 8% per annum. So this is a huge reduction. And RFA undoubtedly saved lives long term. Notice that the relapse rate tends to be in the first 2 or 3 years, and this is the yellow line is overall for all the patients. Blue is low-grade dysplasia. This is actually intramucosal cancer, and this is the high grades, which is the biggest group. But there's certainly lower relapse in low grade. But overall, the relapse rate at 8 years was only 5.9% overall, even in the high grades of the intramucosal cancer grades. Retreatment was able to give you improvements and complete eradication of dysplasia, again, in over 60% of patients with a further up to 2 years of treatment. And what's interesting, actually, is how many treatments it takes to get rid of a dysplasia. So the first treatment only works in about 12% of patients, but in the other 88% or so, if you do a second treatment, 29% it works. In the 70% or so who are left, 40% will get the third go. Of those who are left, 47% will be successful on the fourth, 47% on the fifth, and then after that, it's suddenly you've got the patients who really are difficult to treat. So once you're going to 6 or 7 treatments, you're probably not going to succeed. So I think we've shown it's effective, but actually from a healthcare perspective, what you want to know is it cost effective? And this is one of a number of cost effectiveness analyses that have been done. To the right is more effective. Below the horizontal axis is cheaper, and above the horizontal axis is more expensive, but we're prepared to take a threshold of 20 to 30,000 pounds. So anything to the right of those blue lines is cost effective. And as you can see, the vast majority of simulations that are done actually show that endoscopic eradication therapy for high-grade dysplasia is cost effective at a £20,000 cutoff level. It's quite interesting to wonder whether we could do it more cheaply. So one of the things that we've looked at is whether you can reduce the number of surveillance appointments. And we worked together with Nick Shaheen and his group in America, who they had the US registry. And in the US, when they developed a model from the US registry about an approach to surveillance, and then validated it with the UK registry. With low-grade dysplasia, if you wanted to accept a 1 in 1,000 risk of cancer, you could have only 3 follow-up appointments, 1, 3, and 5 years. With high-grade, you had to have more, but nonetheless, this dramatically reduces the number of surveillance appointments and therefore lowers the cost. But here's another thing, which is even easier, potentially, or perhaps more difficult, is to use argon plasma coagulation. Now, in this randomized controlled trial, APC and RFA, both of them didn't do quite as well as the RFA does in our hands in the registry, but I think there are reasons for that. But just look at the dramatic reduction in cost from APC versus RFA. And I think this is something that probably should be looked at again in more detail in the future. How many procedures is enough to become an expert? You remember what I said, you need 15 per year to be considered an expert center. Well, actually in our data, this is the Q sum or cumulative sum control chart. As the graph goes up, that means you're still learning. As it comes down, it means you've hit your peak number where you are going to have maximum complications, and your complication rate starts to fall, and that comes in at 12 cases. It's not clear to me that you need to have 15 cases per year to be an expert center. You need to have done at least 12 cases to be an expert, that's for sure. And finally, the effect of giving medication to try and prevent these patients from progressing. There's only been really one very big trial, the ASPECT trial, which published 5 years ago. High-dose PPI or aspirin at 300 milligrams per day protected against the composite endpoint of all-cause mortality, high-grade dysplasia, and esophageal adenocarcinoma. And you can see the difference here between the patients who had 40 milligrams twice daily of esomeprazole together with 300 milligrams of aspirin versus those who didn't have anything at all. And there is about a 7% reduction in that rather complicated multi-outcome variable. But nonetheless, it does potentially add some benefit to the patients. And so, ladies and gentlemen, I think it's worth us just considering that endoscopic resection alone is not adequate to treat neoplasia in Barrett's esophagus. There is about a 20% likelihood of recurrence and an 80% likelihood of residual dysplasia. Radiofrequency ablation offers a uniform treatment to the depth of the mucosa itself. Short-term success when done properly is almost 90%, and you can do it within 2 years, and recurrence tends to be pretty early. So that means you can limit the number, the frequency of your surveillance, particularly in low-grade dysplasia patients after therapy. The long-term risk of developing cancer is reduced by at least 90%, it seems, to only 4% at 10 years. It can be retreated very successfully endoscopically if the dysplasia recurs. And I would suggest you consider the value of high-dose PPI and aspirin to further reduce the risks of recurrence, particularly in difficult patients. There's clearly some work still to do on improving treatment, and so the work goes on. Thank you very much indeed for your attention.
Lawrence, thanks as always. I love the way you lecture, and there's lots to unpick in that slide and actually we've had a long morning, and it sort of summarizes the entire journey, doesn't it? From imaging to resection to ablation to follow-up to all of those insecurities that we had back in 2009, 2010, that we were under-treating patients, all of those things that are pointed at us by our surgical colleagues. We're confident, based on your data, based on the Amsterdam data, that actually we've done no harm. If anything, we've probably stopped these patients from getting cancer, although I'm not quite sure we've stopped them from dying from other means. But let me ask you a question about a couple of things. One is, you've shown that in the majority of the patients in your follow-up study, they were still disease-free. Is there anything we can do at baseline that can prognosticate who's going to do better and who's not going to do so well, so we can maybe tease out those patients and maybe look at alternatives?
We've not done any formal work to try and definitively prognosticate. There are some things you just feel like are going to be bad. So what we do know, the longer the segment of Barrett's, the potentially more difficult. But even in long segment Barrett's, you still have very good success rates if you do adequate numbers of treatments. And I think the thing we learned early on was you have to be prepared to treat and retreat and retreat and retreat. And the patients often come in and say, well, 1 treatment, 2 treatments, 3 treatments must be enough, doctor. But actually, we've shown 4, 5. Once you get into 6, you're starting to get a bit worried, okay?
And I think that's a really important consideration, but also the other thing is it's a chronic treatment. If it comes back, I'll treat it in 5 years.
Correct.
And sorry.
God, I always say to my patients, you have to learn to love your doctor.
Well, they will love you. Also there are some, the Amsterdam gastro paper from last year, exactly looking at these prognostic tools at baseline, which is an online tool, which, we'll put in the chat forum later, where you can put in things like highest grade of dysplasia, you can put in, demographic data, length data, which just gives you something to tell your patient in clinic that this is a chance of your success and recurrence. Second point about true recurrence versus residual disease.
Yeah.
So when I look at your Kaplan-Meier's from 2015 and 2018, and then your most recent publication, there's a leveling off after 2 years. So just you and I have always had we've discussed where I have perhaps thought that a true recurrence is not a recurrence of disease perhaps we hadn't treated, When do we need to be most vigilant?
So there is actually a difference between the earlier papers and the later papers. In that last paper, we made a very specific decision that you had to have 2 endoscopies clear of dysplasia before you called the person clear, right? So that's different because earlier on you had more apparent recurrences where in fact it was residual disease because you simply had a single endoscopy which was clear. Now we're much clearer, we're much more certain because you had to have 2 which were clear before claiming that there was recurrence.
And I think that's what I was getting at, Lawrence, is, your message to the audience is that, when you take these patients on a journey of treatment, make sure that that you only call it a day when you've got those 2 negative biopsies. Now, Lawrence, just very quickly, you touched a little bit about chemoprevention there in a slightly different context to the dysplastic state, which is in combination with antiplatelets to look at reducing the risk of progression to dysplasia and cancer. These patients will have often asymptomatic acid reflux and will have hiatal hernias. These are patients that we've treated.
Yeah.
And you will then, tell them that they are free of dysplasia and you will confine them to lifelong acid suppression. They will often have hiatal hernias. They will have volume reflux. What do you do with these patients when they come to you and say, really, you want me to carry on taking these drugs for the rest of my life? What are you going to do about my hernia? Will it come back? Are you going to treat? Are you going to send me for surgery? What do you do? What's the advice? Because a lot of patients ask me this.
Okay, so the first thing to remember is that many of these patients had a terrible shock when they realised they might be about to die, and most of them are really very compliant taking medication. Because actually they remain asymptomatic with the medication. So it's unlike a younger population who've not had severe disease. These people are generally happy to take medicine. However, the patients I get most worried about, the ones where when I go back in, I see pools of fluid sitting in the distal esophagus, and they're still symptomatic, or indeed they have esophagitis when you go back in. You think, well, their Barrett's are just going to keep coming back. And those patients are the ones who I try to send for surgery. And the problem is that they're often elderly and frail and don't want to have surgery.
Okay. Well, thank you so much, Lawrence and Rayhan, and thank you to Professor Voyston, who dialed in earlier. It's been a really, really enlightening session there, and a really great overview of not just RFA but all ablative therapies, techniques, how to do it, and also follow-up, which is critical. So I think at this juncture we'll stop for lunch. I think everyone needs a well-earned break, and we'll aim to reconvene at just after 1:35. So in that time, please don't forget to visit the Gastro Learning portal.